Good morning. Welcome delegates to the District Outreach Program in Hooghly of OSWB. As a ritual we usually maintain in all our CMEs, our president is going to be garlanded by our secretary. I request Dr. Debashish Dash, our secretary, to kindly put the medal on our president, Dr. Debash Mukhopadhyay, sir. Thank you. We all know about the heinous incident that has occurred a few days back in Arjikar, and we are really grieved, touched, and very sad about it. We protest and we want justice for it. In memory of the deceased soul, I would request all of you to please stand up and maintain 1 minute silence. Thank you. Uh, we will directly go over to the sessions, and I hand over the mic to Dr. Shibashish Dash, the chairperson of District Outreach Subcommittee. And before that, before starting the sessions, I request our Secretary Sir, Dr. Debashish Dash, to say a few words.
I'd like to welcome everyone in this August gathering on behalf of my president, Dr. Devdas Mukhopadhyay. We are all going through very trying times, and we are all so deeply mourned and aggrieved with the entire situation which has been going on over the last 10 days, perhaps. We do understand the gravity of the situation which is there for the last few days, and all activities of our societies has been come to a stall. Please do understand that there are logistic reasons, and this program has to be continued in spite of all odds everywhere. I'd request my members not to take individual photographs today, not to post any of these photographs in any social media, be it Facebook or even our closed WhatsApp groups, apparently, which seems closed. To commemorate with the environment everywhere. We do have our official photographer and our official video recording for the purpose of our proceedings subcommittee for documentation, and we will maintain that. Apart from that, please refrain from individual publication of these data. With that, I'd like to hand over to my chairman of the district subcommittee to continue with the program further from here.
Good morning and welcome everyone. For the district outreach program, usually we have a very happy district outreach program, but this time the situation is different. Because of logistical reasons, we had to go ahead with the program, although from OSWB, the other programs in this month have been postponed or cancelled. So this program, we have mainly focused on just the scientific part. We have cancelled all the extra, the fun parts and the other things that we had planned. To start off the program, I would like to request our senior members to come and start with the lighting of the lamp. This lighting of the lamp is more than starting off today's program. It is in memory of the soul who has left us, part of our doctor fraternity, and this lighting of this lamp is a lighting of a hope that whatever it is, the truth that truth should come out and she should get justice for whatever she has suffered.
1 minute, I'm sorry to have a break. Before the lighting of the lamp, uh, we had a pronam program for our seniors. We have two of our seniors amidst ourselves today here who had not been able to be with us during our pronam program. We would like to hand over the memento here even before we start the today's program. Dr. Shomir Ranjan Datta, please. May I request our past president, Dr. Ratish Chandra Pal, to honor Dr. Shomir Ranjan Datta. This honor is the memento. Sir, Dr. Shamul Kumar Pandey, sir. May I request our past secretary, Dr. Shubhashish Nag, to do the honors on behalf of OSWB. Thank you. Thank you. Dr. Devashish Datta, sir. May I request our past president, Dr. Parag Mukhopadhyay, to do the honors. না দেওয়া হয়েছে ওটা সেদিনকেই দেওয়া Honestly, we ourselves feel honored to respect our seniors. On that day also, we are so humbled, and today also, we all feel so humbled to respect our own seniors. Thank you so much. With this, we will proceed with the lamp lighting as scheduled.
I request all our seniors to please come ahead to light the lamp that we want to be enlightened and stay there till the guilty is caught and punished. So this is the light, the candle that we are lighting for the deceased in protest of the heinous act. Senior, please, উঠে যান, sir, please. Sir, please, আপনি আসুন। Sir, এই podium যথেষ্ট বড়, আমরা সবাই আসতে। আমরা ছোটরা নিচে থাকবো। Sir, সামনে থাকুন। This lamp should not go off. It should be there. সামনে একটু দাঁড়াই, sir. The juniors, please join us because this light is for the protest light that we want. এবার একটু এই পাশে ঘোরো। হ্যাঁ, এইদিকে একটু স্প্রেড আউট করো। তুই ঘুরে যা, ওটা ইয়ে দিয়ে করা। যারা হাত দেবে দাও, শুধু একটা হাত বাড়িয়ে দে। চন্দনদি হাতটা বাড়িয়ে দিয়ে সোজা হয়ে যাও। কাজলদা হাতটা বাড়িয়ে দিন। All of us join hands in this protest against this heinous act, and this light will go on till the guilty is punished. Thank you. Not wasting much time, we start on with our first session, and I call upon the chairpersons of the sessions Dr. Shamol Pandey and Dr. Kajol Prasad Ghosh, sir. You can come up and sit in the front row, maybe. Acha. The panelists of this session are the key opinion leaders, Dr. Shubhashish Nag, Dr. Saurabh Sanal, sir, Dr. Malay Sharkar, he's not there, Dr. S.R. Datto, Dr. L.K. Dash, he hasn't reached yet. And the panel, we have Dr. Shudip Boido, who is still not here, Dr. Mondira Shamajputi, and Mohuadi, who couldn't come because of the emergency duty as her residents are on protest. We start on with Dr. Rajorshi Ash. The topic is blowout fracture of the orbit. Let me introduce you to the moderator, Dr. Utish Chandrapal, who's a teacher to all of us. So I'm very sure this session is going to be very interesting under him. Thank you so much, sir. All over to you.
Good morning to everyone. My topic of presentation is blowout fracture of orbit. A 38 years old male patient came to emergency room of Gaurati SA Hospital with history of blunt trauma, left eye by cricket ball. The patient is non-diabetic, non-hypertensive and euthyroid. On clinical examination, visual acuity 6/6 part in both eyes in unrelated condition, periocular ecchymosis and edema, no enophthalmos and pseudostosis, and tenderness elicited on palpation of inferior orbital rim. Infraorbital nerve anesthesia, no epistaxis, ocular movement full in 6 cardinal gauges, no diplopia in any gauges, subconjugal hemorrhage, and fundoscopic examination reveals no Berlin's edema. Now, routine blood investigations, USG B scan, OCT of macula and RNFL, both eye, automated perimetry, NAT. Diplopia charting test in 9 cardinal gauges, no diplopia. But NCCT of brain and orbit, no intraocular injury, but blowout fracture at floor of left bony orbit with protrusion of extraconal fat into left maxillary sinus. That is called teardrop sign or hanging drop sign, with soft tissue swelling over left periorbital and preseptal region. So complication of blowout fracture, cerebral and ocular damage, severe epistaxis, orbital hematoma, CSF rhinorrhea, damage to lacrimal drainage system, lateral displacement of medial canthus, and associated fracture of medial orbital wall with floor. Management. First, we should observe restriction in ocular movement and or diplopia is caused not only by entrapment of the muscle, but also due to edema of soft tissue, hemorrhage, and motor nerve palsy. A better evaluation can be made if time is allowed for clearing of or initial edema and hemorrhage. It is generally accepted that 2-week window period observation can be allowed in absence of urgent surgical indication. Medical treatment includes cold compress, systemic antibiotic, systemic NSAID, seracopeptidase, vitamin C, thrombopop gel, topical antibiotic steroid combination, synthetic teardrop, nasal decongestant, and not to blow the nose to prevent subcutaneous emphysema. Follow-up. At 1-2 weeks and 1 and 2 weeks after trauma, follow-up should be evaluated for persistent diplopia and enophthalmos after acute stage of orbital trauma has been resolved. If symptoms of sinusitis develop or were present prior to injury, the patient should be seen within few days of injury. And fundus examination for peripheral retinal hemorrhage, depending on the level of associated ocular injury, patients should be monitored for development of orbital cellulitis, angular system glaucoma, and RD. Gonioscopy of anterior chamber angle and retinal examination in dilated pupil with scleral indentation is performed 3 to 4 weeks after trauma if hypema is present. Warning symptoms of retinal detachment and orbital cellulitis are explained to patients. Now, surgical technique indication. Where unresolved diplopia with soft tissue entrapment, significant enophthalmos, which is more than 2 mm, and fracture more than 50% of floor, and trapdoor type of fracture where soft tissue is entrapped within the fracture site. And principle of the surgical technique to assess orbital floor, release soft tissue and muscle entrapment, and to strengthen the floor with the use of implant. Now, repair is of 2 types, immediate repair and repair in 1 to 2 weeks. Immediate repair indication is clinical evidence of muscle entrapment and non-resolving bradycardia, heart block, nausea, vomiting or syncope where there is present of oculocardiac reflex. And where repair in 1 to 2 weeks, persistent symptomatic diplopia in primary and down gauge that has not been resolved over 1 week. CT scan may show muscle distortion or herniation around fracture, complex traumatic fracture involving orbital rim or displacement of lateral wall and/or zygomatic arch, complex fracture of midface, skull base, or nasoethmoidal complex fracture, and superior or superomedial orbital rim fracture involving frontal sinus. Cosmetically unaccepted enophthalmos over time due to large orbital fracture or fracture of combined medial wall and orbital floor. It is also reasonable to wait several months to see if enophthalmos develops before offering repair. Now, surgical approach, what are the techniques? Subciliary approach, transconjunctival approach, transantral approach, transmaxillary and transnasal endoscopic surgery to eliminate the incision over the eyelid and as well as improve visualization of the fracture site. Now, implant, membranous bone, cartilage, titanium mace, porous polyethylene, Medport seed, silicon seed, and silexic seed, that is Teflon. Now, complication of surgery, intraoperative bleeding, residual or new onset diplopia, extraocular muscle dysfunction, postoperative neuralgia, residual enophthalmos, implant extrusion, and possible loss of vision. Treatment of persistent handicapping diplopia. Diplopia in primary gauge and down gauge are more troublesome. Inverse NABDOR procedures in performed to correct diplopia in down gauge. It is very
Rajesh
rare procedure.
Rajoshi, can you please wind up?
One please. And Fresnel's prism can be employed in selected cases. Now, late treatment of cosmetically unacceptable enophthalmos, resurgery with orbital implant of adequate size if downward sinking of eye along with enophthalmos is unacceptable to patient, and correction of pseudotosis done with molarectomy. And last but not the least, orbital blowout fracture in children. In case of children, bones are more elastic than adult. So in this case, injury in children causes more anteroposterior buckling, creating a trapdoor fracture, where severe mobility restriction and diplopia are seen in absence of marked congestion or ecchymosis. This is called white-eyed blowout fracture. And
Can
last,
you go to
role
the
of anticoagulant
last slide, please. Can you go to the last
this
slide?
is last. Role of anticoagulant is debatable. Anecdotal reports have described orbital hemorrhage in patients with orbital and midfacial fracture who are anticoagulated for prophylaxis against DVT. On the other hand, multiple large studies have also demonstrated increased risk of DVT and pulmonary embolism in post-operative cases. At the very least, all in patients with orbital fracture awaiting surgery and all post-operative orbital fracture should be placed on intermittent pneumatic compression therapy and encouraged to ambulate. So in case of patients who are at high risk for DVT and who are obtunded from concomitant intracranial injury, a detailed discussion regarding risk for and against anticoagulation therapy should be done with patient party. Thank you.
Rajarshi, specific what treatment you did for this particular
In this
case?
case, as there is no diplopia and enophthalmos, so conservative treatment is necessary.
Now, coming to opinion of Saurabh Chanal, if this case would have been come to you, how you are going to approach? Because there is a frank, floor fracture.
No, it's a floor fracture, but there is no diplopia, and there is no sign of entrapment. Even muscle entrapment, not only muscle entrapment, but the sheath entrapment also can cause some amount of diplopia. Sometimes the muscle is whole, doesn't herniate. So in those cases, conservative management.
But I can see the muscle is also entrapped. Look at the inferior rectus muscle. Can I get a pointer here? Just pointer. See, look. See, these are the four recti muscle. The inferior rectus will be horizontal in position, transverse, but it has distorted. It has gone inside this. Got it?
But the report of CT scan reveals the only soft tissue entrapment, no muscle entrapment.
No, point is this, Chandonadi, number 1 point, fine, he is complaining that the patient in both primary gauge and in the all other gauge, there is no normal, this is orthophonic. So how you can explain it?
You have any diplopia charting?
How you can explain it?
Now,
Question is
you
this.
have to show the diplopia charting here. But if your patient doesn't complain
in
anything,
9 fields there is no diplopia.
if the patient doesn't complain, then you can leave the patient.
Now also chart, we have give
In
chart.
the primary position or in the inferior gauge,
And in 9 gauges.
no diplopia.
No diplopia.
But the muscle has gone inside.
definitely cause some amount of enophthalmos.
Now, enophthalmos you cannot compare because both eyes are not there.
No.
Both
He has
eyes are not
compared.
there.
He has compared.
26
He said
June.
there is no enophthalmos.
26 June
But the
patient was
amount of
admitted.
fat prolapse, there must be some
Last
amount of
picture, sir.
enophthalmos. May not be.
Okay.
This is the present picture.
This is the present picture. Now next question is how long you are going to observe it, follow it up. And in which frequency? Because this is also another point of interest is this, something which is evident on your examination part, especially in the radiograph, which is not correlating with the clinical what is called manifestation. So how long you are going to evaluate it and in which in what frequency? There is no anesthesia, no diplopia, and no what is called
Enophthalmos.
Huh?
Infraabdominal anesthesia. Yes, if a huge amount of inflammation is present, you can advise steroid. I use NSAID, aceclofenac sodium. And according to Kansky, small fracture without herniation does not require surgery. And large fracture less than 50% with minor entrapment without diplopia does not require surgery. Only large fracture more than 50% of the floor with entrapment and persistent diplopia.
So the instruction has come. Thank you. You had Rajarshi did a wonderful job. Dr. Anirban is the next presenter.
A case of glaucoma in elderly female. Dr. Anirban Bosch is probably the youngest ophthalmologist of this district. So all over to you.
A very good morning to all the seniors. Today I'll be discussing a case of normal tension glaucoma in a very elderly female. So we all are aware about normal tension glaucoma. It's considered to be a variant of primary open angle glaucoma. It is a chronic progressive optic neuropathy. There is open anterior chamber angle with optic nerve damage, and the IOP will generally be less than 21. So it has an increased prevalence in individuals over 60 years of age, and there are various risk factors: age, family history, ethnicity, myopia, diabetes, hypertension. So I'll come directly to the patient particulars. She was an 86-year-old female who had come in 2017 for her initial routine checkup. She had come with gradually progressive diminution of vision with occasional headaches over the past 12 months. She also had a gradual loss of vision that was seen over months, greater in the right eye compared to the left eye, associated with headaches, and especially after watching TV or after reading a book. There were no history of previous trauma or vision loss. She is an hypertensive lady. She is non-diabetic. She had a bilateral knee replacement in 2018 and a pacemaker implantation in 2022. So she had undergone cataract surgery in 2008, which was uneventful. SLT was done in 2019, which I will later talk about as a part of the case, but it did not halt the progression. There was no history of glaucoma or any other ocular pathology in the immediate family. She was a non-smoker, no history of alcohol, drug abuse, and she lived with her son. She was on a cocktail of medications, cilnidipine, telmisartan, alprazolam, aspirin, atorvastatin, and for the past 10 years, she had been taking them without any side effects. She was prescribed bimatoprost before she had come to visit us in 2017. And she had said that there was an intolerance to brimonidine, brinzolamide, and probably timolol during that period. So on ocular examination 2017, we found that she had a best corrected visual acuity of 6/6. Her IOP on applanation tonometry was also found to be normal. She had a wide open angle. But on fundus examination, we saw that there was a cupping of 0.6 and 0.5 respectively in the right and left eye. Small neuroretinal layer defects were seen, greater in the right eye compared to the left eye. There was also a subtle RNFL defect that was noted in the temporo-inferior and temporo-superior regions in both eyes. So it will be there, ma'am. It's in the progressive slides. Okay. So visual fields, we found we had some data regarding the 10-2 in the patient. I unfortunately could not find the 24-2 which she had gotten in the previous encounter. But If we see from 2018 to 2022, that was the follow-up that was done, you can see that if we see the grayscale picture and if we compare, we are seeing a significant change here. Even on the left eye, you can see that there is a small progression in the perimetry. Now again in 2021 when this was done, again that similar picture in the right eye, and then again in 2024 after complete therapy was done, this was a near total glaucoma, perimetric glaucoma that is observed. In the left eye, she was also showing progression. Now this is the OCT RNFL picture. If you can see, this was done in 2017. So this was the picture in 2017, and if you can see, there was a slight improvement from 2017 to 2018, and then again in 2019 the deterioration started. So this is 2019, 2020 and 2021. This was for the right eye. Now coming to the left eye, again in 2017 this was the picture. She had an inferior defect, and then it was again followed in 2019. This 2019 picture was done after the SLT that was performed. So then again progression was noted. Again in 2021 there was a arrest in progression, followed by progression again started in 2024. This is the OCT macular picture, which was generally unremarkable for this patient. Whenever we did a fundus examination, we didn't find, other than the RNFL defect, we had not found anything. When we come to the ganglion cell complex, this is for the right eye. You can see this was 2017, this was the ganglion cell picture. Then again in 2019, this was the picture, and then 2024, it was like it had completely disappeared. This was the ganglion cell complex that we had found. This was the only document, unfortunately, I could get from her. This was the ganglion cell complex in the left eye was slightly better than what it was in the right eye. In the right eye, it was almost completely gone. Now this was the details of the ocular examination that we had performed in 2024. Her vision had come down in the right eye, which was 6.6 in 2017, had come down to 6.12 part. In the left eye, it had come down to 6.9. She again came back to us in 2024 with sudden decrease in vision. The IOP was found to be 28, and in the right eye, and in the left eye it was found to be 21. Angle again was wide open, but the cup disc ratio from 0.6 at the time of 2027 had changed to 0.9 in the right eye and 0.85 in the left eye. Neuroretinal thinning had increased. There was, in the 10-2 picture, again we found that naso-inferior, naso-superior regions were almost completely involved in the right eye, and greater than 50% involvement was seen in the left eye. Her pupillary reaction had started to show slight sluggishness, which was more in the right eye compared to that in the left eye. So now, this is a question that I put forward to the audience. What were the issues in this case? Number one, she was an old lady with osteoarthritis. She had already undergone bilateral knee replacement, but still her restriction of mobility was there. She had severe dry eye disease, which was understandable. She had a severe meibomian gland dysfunction. Systolic hypertension. She was often in the period between 2017 to 2024, there were spikes in hypertension which led her to be hospitalized. Her diastolic pressure was suddenly found to be low since 2023. From 2023 to 2024, she suddenly saw a decrease in diastolic pressure, which had reduced to less than 60 in most cases. Again, when brimonidine, brinzolamide and timolol were tried in this patient, it was found to be, she was allergic, she was intolerant. There was progressive visual loss despite normal IOP, and SLT had no or minimal effect in this patient. So what are the options now? Now, newer IOP lowering medications like Rho kinase inhibitors have been discovered, and they can also be tried in this patient. Her diastolic BP spikes, which was going down below 60, needed to be addressed, but unfortunately we don't have any medication which directly targets diastolic BP. Trabeculectomy with MMC under mannitol for the progressive eye has been planned. She is due to undergo it in a few days. And eye stent or MIGS for the better eye for better diurnal control may be a better option for this patient. Yes, ma'am. Sir, she had a sleep apnea scale of 5 when we had done a polysomnography. We had asked her to consult a chest physician. They had put her initially on a CPAP, but later on she found that with little bit of reduction in weight, the scale, the score which was 5, it dipped down to 3.5. So then that therapy need to be continued. Right now she's a 93-year-old female, sir. Yes, sir. Yes. Yes. Yes, sir. That is why we planned for a, she has been planned for a trap. In a few days she is undergoing trap with MNC. Primary open, yes, sir. Yes, sir. Initially it was. Yes. Not now. Now the diagnosis has changed to primary open. Yes. Yes, yes, sir. We, in the initial period from 2017 to about 2019, we had done a diurnal check. She lived nearby. We tried to call her. We did it. We tried calling her twice. We did applanation tonometry. And we found that there was not so much of diurnal variation in the initial part of her diagnosis, about 2029. She takes a multivitamin supplement which contains vitamin B12, but it is not at the highest dose that can be given to the patient. Serum vitamin B12 and folate was done, sir, during her, she had undergone knee replacement in 2018. And during that portion, she had, yes, I forgot to mention, she had an acute blood loss episode during that phase. So that has probably resulted in, when she came to us in 2019, there was a sudden increase in the glaucoma. We saw a sudden progression. That was probably the reason. And
was there any nighttime antihypertensive?
yes.
Normotensive or the low tension glaucoma, did any of our colleague has found that later on that there is an increase of the pressure? I have 2 or 3 cases, the low tension or normotensive, but I never saw any rise of the pressure. I am asking my colleagues whether they have faced all this. Age that was started about say for 50, 60 like that. Pseudophakic. Both eyes I have done that.
This is one of the yet to
Find a significant diurnal variation up till 2019.
Initially, when it was diagnosed as normal tension glaucoma, was she on any nighttime antihypertensives?
She was on bisoprolol.
No, was that nighttime?
It was not in the night time, ma'am. We had actually, when she was diagnosed in 2017, we had written to the doctor. She was actually having a beta blocker in the evening. We had written to the doctor asking them to try and shift that into the onto the morning time for a long time. For about 5 or 6 years she was on a beta blocker. After that, when she underwent pacemaker implantation, all beta blockers were stopped, and now she is no longer on a beta blocker.
And was she allergic to dorzolamide also?
She was allergic to dorzolamide. Yes.
I think you had mentioned.
Yes. I have not mentioned dorzolamide. She was also allergic to. She was even allergic to acetazolamide oral tablets. So probably the entire group.
So, and did you do a repeat gonioscopy later on?
Yes, ma'am. When she had, we tried to do a gonioscopy annually. But because she was an old lady and she was unable to come to us for follow-up, so probably it was done every 2 years.
Yeah, in a pseudophakic patient is not indicated.
But even if she is pseudophakic, I think the protocol says that, sir, we have to do it annually.
In a case of normal tension glaucoma, do you need acetazolamide orally? No.
Usually no.
no. That means he has tried it, oral acetazolamide. That means.
And primarily is notorious to cause allergy reaction.
ठीक है, okay, these are all.
And CT scan was necessary, like to rule out any. And a color Doppler also could have been done to find out. And one more is.
Thank you.
Bringing this
Muazzam.
topic up because I was a little confused with the diagnosis at the end.
Hello. Hello. I have one question. What was your target IOP previously and whether you are able to maintain it?
To us first, we had decided a target IOP of 30. We had decided a target 12 to 13 in the initial stage. But in 2019, when our accelerated loss had happened, we decided to reduce that another 10%. So 40% was our target IOP then. But even then, even after doing so much, now ultimately I don't have any option other to do a trabeculectomy, maybe a eye stent in the other eye, I think.
Next is Dr. Muazzam Parvez, tackling the toricity.
Good morning, respected seniors and my colleagues. I'm here to share my first few toric cases I have performed. So I would like to start my presentation with quoting Dr. Abhay Vaswada sir, where as advances in technologies and techniques continue to erode the boundaries between refractive and cataract surgeries, M-metropia has gone from an exceptional result to an expected outcome. Talking about the basics of toric, a lens whose cylindrical surface is curved in both the horizontal and the vertical meridians is called a toric lens. The principal meridian of minimum curvature is called the base curve. Each meridian of curvature forms a separate line focus. The distance between this is called the interval of Strum. The spherical equivalent is calculated by adding the spherical power and half of the cylindrical power. Before going for a toric case, we have a few checklists. Avoid patients with ocular pathologies, small pupils, or progressive retinal problems. We should perform biometry in both the eyes, and an A-scan immersion or optical biometry with a good graph is preferred. K-metry with axis and latest generation formula. A Barrick toric calculator is available on the website APA-CRS. Apart from that, various other websites also do provide the calculator where the K1, K2 values, anterior chamber depth, and other patient details are entered to actually find the axis at which the toric lens is to be implanted. The toric mantra would always be about marking, remarking, implanting, and aligning. So going for the pre-op marking, a bubble marker is used where the patient is made to sit on the OT table and aligned with our visual axis. A speculum is spaced and the markers are dipped in trypan blue dye. The bubble is aligned in the middle compartment of the bubble marker and placed on the eye, and 0, 90 and 180 degree is marked. This is a Mendes ring. The outside ring is the Mendes ring. And the inside one is an axis marker which is used to do the post-operative marking for the toric lens. This is a picture snap of the intra-op marking done with the Mendes ring in situ. This is the video of my first toric case. Here, to start with, the places where it's to be marked, it's tapped with a bud to make it dry and for proper staining. The Mendes ring is placed and the markings are done. Over here, a Sinskey hook dial, Sinskey ball dialer is used to do the precise marking. So this is the second time we are doing the marking, once done pre-operatively and now intra-operative axis marking is being carried out. After this, a conventional cataract surgery, phacoemulsification is done where we do a good 5 mm central continuous curvilinear capsulorhexis. It should be well centered to avoid further after rotation of the lens once the lens is implanted. So a careful 5 mm CCC is done. conventional trench and chop femcoemulsification is attempted and performed, avoiding intraop meiosis so that lens implantation doesn't become an issue in the long run. Cautious cortical cleaning is done. The rotational stability, the lens is inserted into the cartridge. Off-axis reduces the corrective cylindrical power. More than 30 degree of rotation will cause complete loss of toricity. The lens is loaded and implanted. The visco is expelled out and the lens is dialed properly, marking with the markers which we have done intraoperatively. Meticulous viscoaspiration is done to avoid any further rotation of the lens once the lens is aligned. The visco behind the IOL is also expressed out. So the checklist summary would always be about making a good proper 5 mm CCC, intraoperative axis marking, IOL placement before 1 clock hour so that proper rotation of the lens is possible, OVD cleaning behind IOL, final IOL adjustment and tapping of IOL to check if any OVD is left behind, hydration and recheck. Post-op checkup, we will be checking the vision, the corneal clarity, IOL position in a dilated eye and avoid doing auto-ref over a toric IOL. Thank you.
Dr. Parvez, you did wonderful. Any comment from anyone?
So this is my initial cases after, like recently I am trying to do it in hydro. Previously I was doing it in visco, yes sir.
One point I will highlight, this is remain not observed always. While you are going to close the wound by hydration, so what is the target, intraocular pressure you want to keep and how do you assess it? Because if you overhydrate, that will be more inflation, inflating the eye. So it will be in wide area, there is chance of rotation. If you less hydrated, then again there is chance of collapse and going in reverse direction. So there is a norm. How do you go about it?
So we do hydration to check that there is no leakage so that it avoids rotation.
One point. Anything else? Usually we try between 18 to 20. 18
yes,
to
sir.
20. Now how do we do it? Tumra ki kore koro, Shivashish? How do you check? Because most of the cases are done nowadays under topical anesthesia. Isn't it?
So doing it multiple times, small amount of pressure is given and changing the ports and doing it 2 or 3 times.
Right. Anyway you do it. So this is the point of interest in case of, because sometimes we blame the company, sometimes we blame the marking, but these are the few small things which makes a lot of difference.
Yes, sir. That is not to be done. I mean, like that has come in the video. Just to form the AC. Initially, when I was about to enter, that time the AC was not completely formed. So I just went inside with the irrigation just to make the AC depth proper, and then entered with from the port.
If your axis size is big,
right,
and there is a chance of rotation of the lens. So when you are doing like a normal lens, usual, not a non-toric lens, then your exercise you can make it up to 5.5 or even up to, in some cases, hard cataract, you go up beyond that. But in a toric lens, you try to be within 5 millimeter.
Yes, sir.
Because if the exercise is more, there's a chance of rotation is always there.
Thank you, Dr. Parvez.
Thank
you
you,
did something wonderful, commendable. Your
Thank you,
surgery was beautiful. Who is next, Sudipta? I think he needs a big clap.
Rituparna, will you present your case? Yeah. Dr. Sahid Alam is absent, so in place of that, Dr. Rituparna they will be presenting her case. Please come. Rituparna, we all know, is a very experienced glaucoma and cataract surgeon, and Rituparna belongs to this district very much. Her schooling has been here in my school. Yes, of course. Sir, we have. She is from my school. She is from my college. She is in my hospital. So. Rajashri is also from college. No, there are many Arjikarians here. But school also we had others too, like Rituparna Chatterjee. We had Mohuadi, Mohua Sengupta. So all of us are from this school and from this place. Jonaki. Nisha and Chandri are from St. Joseph's, Chandanagar. Nisha, late Ashpe. Yes, all over to you.
A very good morning to everybody here. Thank you OSWB and thank you Dr. Sudipta Di for allowing me to speak here. I'll be presenting some clinical scenarios. The first case, a 60 years old male, he came for a regular checkup with no complaints regarding vision with glasses. He had no family history of glaucoma. His best corrected visual acuity was 6.6 and 6. The slit lamp examination was fairly within normal limits except for an early cataract. The applanation tension was 14 millimeters of mercury in both the eyes, and gonioscopy showed angles open up to scleral spur. The fundus examination showed retinal examination which was within normal limits, and the cup-disc ratio was 0.7 with an inferior rim thinning, and the left eye showed a cup-disc ratio of 0.7 with a doubtful inferior rim notch. So a DVT disc photo and OCT with HVF pachy was advised. The pachymetry was a little bit on the lower side. Here we see the disc photo where we can see a early inferior rim notch here. A DVT showed the range of IOP in the right eye was 10 to 12 and the left eye also was 10 to 12 millimeters of mercury. The field test in the right eye was within normal limits, while the left eye, it was a little bit on the borderline side and a little bit on the low reliable side. So we ordered an OCT, and the OCT in the right eye was fairly okay. Left eye confirmed an inferior rim thinning. So the patient was advised bimetoprost in the left eye alone at night. The second case was a 50 years female who came for a second opinion for glaucoma with no suggestive family history. She was on timolol maleate and atlatanoprost eye drops in both the eyes prescribed elsewhere when she came in. Her best corrected visual acuity was 6.6 and 6 in both the eyes again. The anterior segment showed an AC depth of grade 4 with applanation tension of 18 millimeters of mercury in both the eyes. The gonioscopy showed angles open up to scleral spur. The fundus showed a cup-disc ratio of 0.6 with a NRR okay, while in the left eye there was a 0.8:1 with an inferior rim thinning. There was no obvious RNFL defect and the retina was attached. She was asked to stop anti-glaucoma drugs and recheck the IOP after 3 weeks and was ordered a DVT after 6 weeks. On the first review when she came in, she was on no anti-glaucoma medications and her applanation tension was 17 millimeters of mercury with a normal pachymetry. The DVT ranged between 17 to 19 in the right eye and 18 to 19 in the left eye. These were her fields which were within normal limits in both the eyes, and the disc photo showed large discs with a large cup, but this patient did not need any treatment and she was asked to follow up after 6 months. since the OCT also showed that it was there was no significant RNFL thinning. So she was asked to review after 6 months. The third case came for a second opinion for glaucoma. He was on irregular anti-glaucoma medications and his vision was 6/9 in both the eyes. The applanation tension was 19 millimeters of mercury in the right eye and 18 millimeters of mercury in the left eye. The anterior segment was within normal limits. The right eye had a pseudophakia, left eye had an early cataract. The cup-disc ratio in the right eye was 0.7:1 with an early inferior rim thinning, and the left eye was a 0.8 CDR with a superior rim and early inferior rim thinning. The pachymetry was within normal limits. The HVF in the right eye was fairly okay. In the left eye, it showed inferior defects. The OCT confirmed the inferior RNFL thinning, significant inferior RNFL thinning, and so she was advised for latanoprost eye drops only in the left eye alone at night. The fourth case was a 55 years old male who came with dimness of vision in both the eyes for past 8 months. He was on a beta blocker since 2019 and was started on bimatoprost with dorzolamide timolol combination elsewhere 3 weeks back, when his applanation tension was 38 in the right eye and 19 millimeters of mercury in the left eye. The AC depth was Van Herrick's grade 3 in the right eye, and left eye was Van Herrick's grade 4. The applanation tension in the right eye was 25, while it was 16 millimeters of mercury in the left eye. The cup-disc ratio in the right eye was 0.6:1 with the left eye in the advanced cupping. So what would you do next? We did a gonioscopy, and it showed scattered PAS in all the quadrants, peripheral anterior synechia in all the quadrants. So we went ahead with the YAG peripheral iridotomy, and 1 week later, the PI was patent, and the applanation tension in the right eye was 15 millimeters mercury, left was 16. And the angles had opened up to 180 degree. So a careful and repeated gonioscopy can save an eye. And we always still need to look at the overall picture in making decisions regarding treatment. Thank you.
Yeah, she did a wonderful job. If anybody has to add any point, any questions, yeah? Yeah, whatever, yeah.
What do you mean by advanced cupping?
Where the neuroretinal rim is almost absent. Okay. And it has to be corroborated with the fields also. The disc, not the disc alone.
Okay, thank you so much, Rituparna. With that, we have Dr. Chandana Chakraborty next with orbital granulocytic sarcoma, an initial presentation of AML. The next speaker is Dr. Amitabh Kundu. You're ready, right?
A very good morning to all the faculties here and the dignitaries. And when I started my career in medical education service, I presented my first case in National Medical College under the banner of OSWB. One of the faculty told, you people are junior, so you can do case presentation. But I am continuing the case presentation and I am publishing case report because this is a subject which is very close to my heart. To start with, this was a case of a 22-year male with a swelling and redness, proptosis for progressive diminution of vision for 2 weeks. And there was no such remarkable thing in the general history of present illness, no neck swelling or nothing was, systemic history was not remarkable. Ocular examination in the right eye visual acuity was 5 feet. There was a relative afferent pupillary defect. There was disc edema. There was exposure keratopathy and lagophthalmus. And the pulsation and all were absent. It was a firm mass. It was a non-tender. No lymph node was there. So we did an NCCT. As you can see in the NCCT, there is an NCCT and MRI, all we did. There is a lesion. There is an isodense lesion in the CT, axial CT. And In the MRI also you can see this is involved with the inferior and the lateral wall of the orbit is an extracorneal mass lesion. We did the CBC because we had a strong suspicion that it could be a case of hematological disorder. So we did an CBC. Atypical cell was 45%, ESR was very high, and hemoglobin was low. There was WBC count was very high also. And after that, we sent the patient to tropical medicine. They did the bone marrow biopsy, and it came to be a case of acute myeloid leukemia. So one day the patient was referred from there. The patient was having hemorrhage and severe proptosis. So that time we just did an tarsorrhaphy, and they themselves did the chemotherapy and all. And this is the picture with an corneal, as you can see, at the end of the 2 months, the patient has just a corneal opacity, but the patient improved a lot. So another case I am going, this is a case of 14-year male, swelling of the lower eyelid and the right cheek. This time the patient, there was a right submandibular preauricular lymphadenopathy was there. The blood picture was NAD. CT scan, as you can see, there is a mass lesion, isodense lesion in the maxilla, and in the axial CT also there is an invasion of the orbit. So what we did is an orbital biopsy. And the result, they said that pathologist told it is query AML. So what? See, the patient lost to follow-up. After 1 month, the patient came with this type of picture. So this time we did a bone marrow biopsy with the help of the hematologist, and there was focal blast cell proliferation. And the repeat CBC we did this time after 1 month, and that came to be clearly abnormal blood cell and a clear-cut case of acute myeloid leukemia. We sent the patient to Tata Medical Center. Chemotherapy was done, but the patient lost to follow-up. So just a few words about this myeloid sarcoma. Myeloid sarcoma is, there are various nomenclature. It can be called granulocytic sarcoma. It can be called chloroma. And at what it is usually, these are actually an extramedullary deposition of the myeloid cells. This can occur either at the beginning of the concurrently with the AML when the blood picture is there, or it can occur before the acute myeloid leukemia start with, or it can occur even when there is a relapsing phase or recurrent phase. You can get this myelocytic proliferation. These are actually very rare cases. In data we have seen only 2 to 9% of these AML actually they produce this type of picture, that is these cells can be deposited, extramedullary deposition can occur, and the skin, common are the skin, the testes, the breast. Rarely it can occur in a case of orbit. And adults are the most commonly involved, then and children. So these, when the patient comes to us in case of child, this should be differentiated with the rhabdomyosarcoma or a metastatic neuroblastoma, or in case of adult and pseudotumor, and histological differentiation is very important. This time, this is myeloid sarcoma. Nowadays, it is rather than straightforward going to just histopathology and chemotherapy, there is a wide array of investigations that they have asked. You have to take the analysis of the molecular analysis is very important. The immunohistochemistry is very important to see what is the treatment guideline, because not only chemotherapy, what type of chemotherapy you are giving, what is the risk factor, all these things will be decided by your molecular analysis and your immunohistochemistry. The take-home message is that proptosis can be a sole presenting feature of an acute myeloid leukemia. Peripheral blood smear and bone marrow biopsy can aid in early diagnosis and better management. Though the prognosis is actually very poor in a case of myeloid sarcoma. Thank you. Any question? Hello. Uh, One is that when the patient comes to your clinic, at a glance, if you look at the patient, see how much, what is the facial picture of the patient. Definitely you will see some amount of anemia is there. The patient is pale looking. That is very important. And this is not a very acute, it is not an acute case usually. It's a subacute presentation. And usually it is a non-tender. There will be chemosis. The disc edema is usually there because it is pressing, the mass is pressing. The mass, it can be cellular infiltrate. That is there. It is a solid mass.
No, when you are seeing a patient with proptosis, you do some blood tests, including thyroid. When you are doing the blood test,
see, thyroid is a typical thyroid presentations will be there. The lead signs and all.
when we see a patient with possible proptosis, we do some blood tests that includes thyroid. That includes. Now with the routine blood test, that was what do you call it? Routine blood test. Do you expect any abnormality in the cell count or in the that is the hematologist will give us the report that will indicate it might go in that direction.
Definitely, that is in my second case, as I told, there was no blood picture was positive for the AML. No blood picture. When it can occur, the two things can occur. One is that somebody or myself maybe has treated the patient as a case of pseudotumor and given corticosteroid. So that can wash out the picture of the blast cell. So that is very important. So you have to wait for the steroid washout effect and then go for the blood picture. This is one. Another thing is that there is a special entity itself called de novo myeloid sarcoma. Even a primary myeloid sarcoma can occur without AML at any time of presentation. That is very, very rare, primary myeloid sarcoma. But always you have to keep it in mind that this could be your clinical diagnosis is very important, that then you have to confirm the diagnosis with all these things. Even if your blood picture does not come, you have to send the patient for a bone marrow biopsy, like in our second case. But one important thing is that you have to go do it very fast. Because the chemotherapy should have to start very fast. That is very important. You cannot just waste time. Thank you.
Our next topic is dual polymer advantage in the management of dry eye by Dr. Amitabh Kundu.
Good morning, respected seniors and colleagues. I will be talking about dual polymer advantage in the management of dry eyes. It's a sponsored talk. Dry eye is an enigma for me, and I think for most of my colleagues. And we are in search of a perfect drop to solve the problem. Data loss is there some. Anyway, it's in this way. The prevalence is variable in worldwide studies, but in India, the LVPI studies showed average prevalence of 16.5%. There are various types of treatments. I'll skip that for paucity of time. The mainstay of treatment is artificial tears. The first generation drops are saline based with preservatives. These are not available nowadays. The second generation drops are of natural and synthetic polymers with gentle preservatives or no preservatives at all. In the third generation, hyaluronic acid is added, and the fourth generation contains lipids also. The most commonly used viscosity enhancing agents are polyglycols and HPGOR as well as sodium hyaluronate. HPGOR and polyglycols have an unique property. The HPGOR is pH sensitive and its higher pH of 7.8, which is prevalent in dry eyes. HPGOR forms a reversible cross-link with borate, resulting in a gel matrix with mucin, and thus provide lubrication, retards tear film desiccation, enhance tear film stability, and serves as a natural bandage to allow the repair of the surface epithelium. What I talked. Then come hyaluronic acid, sodium hyaluronate. Sodium hyaluronate is ubiquitous in our body. Its concentration is different in different tissues. It has three unique properties. Number one, it can hold a large amount of water and resist evaporation. Number two, it binds with fibronectin, and this hyaluronic acid fibronectin complex enhances wound healing and wound closure. Third but not the least, the third last and not the least is the viscoelasticity. During blinks, just a minute. The molecules of sodium hyaluronates is arranged in such a way that during blinks they compress, and during opening up of the lids they spread up in such a way that the surface never breaks. That is the unique thing about the hyaluronic acid. So here come the magic thing. Few companies have incorporated polyglycols, HPGOR and hyaluronic acid in drops to get the dual benefit, that is the HPGOR acts as a mucomimetic and sodium hyaluronate preserves water, viscosity, as well as promote wound healing. These things are tested in vivo in mice model. I am skipping those slides actually. All these things in corneal epithelium protection, all this done in mice model, and always this bar is higher than the others, the combination one. So the take home message is the dual polymer, pardon? Oh, acha, ota asche. Next slide. The dual polymer tear substitute provide increased tissue hydration and lubricity and protect the ocular surface from damage associated with dry eye, helps in maintaining the tear film stability, provides significantly greater cell viability than the individual single polymer formulations on the desiccated corneal epithelial cells, and it helps in reepithelialization of the corneal wounds by accelerating wound healing process. As I told, it's a sponsored drug. So these are the products of the sponsorer. Thank you. Thank you.
Thank you so much. With this session comes to an end. And yes, we'll write this product that you have recommended. I think all of us will write that. So with the next session, we come we come to the video session with the end of this session. And I request the chairpersons of the next sessions to come in front, Dr. Shekhar Sharkar, And Dr. Devdash Mukhopadhyay sir is here. Dr. Shekhar Sharkar. The key opinion of this session are Dr. Debashish Das, Dr. Pradeep Banerjee, Dr. Pankaj Saxena, both of them are not here. And panelists Dr. Monomoy Banerjee, Dr. Orindam Shadhu, Dr. Anindo Gupta, and Dr. S.S. Jana. So anyway, the speakers, we start on with Dr. Debashish Dotto, all in one. All in one, Titanic salvaged. We know Dr. Debashish Dotto is a prolific surgeon and a very good presenter. And the moderator of this session is absent, Dr. Rupak Bishash, our scientific committee chairperson. So I would request Dr. Shonji Banerjee to kindly moderate this session. Definitely we can have more discussions.
Good morning, everybody. At the outset, I thank everybody, OSWB and the organizers, Dr. Shudipta Mitra, audio nahi kichu, for arranging this conference in difficult times for our fraternity. Respected seniors, we go ahead with this. So this is a subluxation male subject. It is 63 years with a good visual acuity, but there's total traumatic dislocation of the lens, 7 except at 6 o'clock. IOP is normal, pupillary node sphincter tear, retina is normal. Now, I plan to, here's the lens which is dangling, which is fixed at 6 o'clock. Sorry for the field of video. So I plan to take it out by SICS and other means. So you see the nucleus dangling, but it has not fallen down. Side ports are made, triamcinolone acetated vitrectomy is done from the limbus, and as far as practicable, under vision, irrigation is maintained in the anterior chamber. As we are planning a scleral fixation, diametrically opposite poles are marked, and it is a Halon GV. Halon GV is injected through the pars plana by a 26 gauge needle. Just below the 6 o'clock, so there's the vitreous being pushed up by the nucleus crystalline lens is pushed up from behind. Now I increase the entry wound and a routine SICS is done. Very carefully, obviously, you cannot exert too much of pressure because there's support not from the vitreous but from the Halon. Now the capsular hooks are placed and hydrodissection is done. So it is fixed at 6 o'clock, so we place only 2 hooks. So the 3-point fixation of the bag at this point of time. The nucleus is coaxed out with the bag carefully, bimanually, then under cover of viscoelastics to take care of the endothelium. It is taken out by a vectis basically. And visco expression of the nuclear material is done. So after removing the cortical remnants, a CTR has to be put in because there's no other way if you want to preserve the bag. Otherwise, but it seems too difficult because the pressure of the bag slips from the MST capsular hook. So after we replace the hook, now I try it with CTR injector, but still then the way it goes in, it does not seem that it will be able to fulfill the purpose. The bag will be just ripped off. So it's a bimanual technique I'm trying. I hold it with an end gripping forceps, and at this tip, the CTR carousels and maintains a bend somewhat akin to the equator. And once it is somewhat, the equator has been delineated, I let it go. And then you inject the CTR as usual to the remaining part. So the bag is somewhat in place. And a pars plana port has to be made because the Halon GV that has been put in needs to be taken out. Now, here's Hoffman-like pockets, scleral pockets are made. A true Hoffman pocket is one which does not remove the conjunctiva, but here I have removed the conjunctiva, so it's not a true Hoffman pocket, but it's a scleral pocket through the limbus. The eye of this armored segment is placed, and now the sulcus is exposed. So the sulcus is 2 millimeter from the limbus. So a 26 gauge carved needle is used to railroad out the proline suture which has been put in. Now we negotiate this armored segment to support the 12 o'clock of the equator, and from inside the pocket the two ends of the suture are retrieved and the knot is embedded in the scleral pocket. Now the sulcus is deepened rather, and multipiece lens is placed in the sulcus, because I am not sure whether the bag will be able to hold the lens or not. So it is placed in the sulcus, multipiece lens, and it is centered properly. And then the remaining hyaluronic acid is removed from behind the capsular bag from anterior vitreous. We check for any vitreous in the anterior chamber by triamcinolone lumen, and because some amount of vitrectomy has been done, there is a chances of hypotony, so the wound is closed with a suture. And the ports are cauterized. We check, and a little bit of triamcinolone is left in the anterior chamber to take care of the inflammation. Thank you.
Thank you. For the opinion leaders, can I just ask you a question?
Please.
Yeah, how long back have you done this case? Like how many follow-ups? How many years maybe?
1 or 2 years maybe. It was done in 23, so 1 year follow-up. And sometimes the Gore-Tex is a better option.
Absolutely okay, I guess. Patient is absolutely okay.
Should be. But after 1 year time, but these things heal up so nicely that with these pockets, you don't, unless you go through the papers with the patient is carrying, you don't get to know.
Do you have some case which you have followed up for long, maybe more than 7-8 years?
Yes,
something like this.
There are.
And with CTR and Ahmed valve and subluxated
they don't usually follow. Basically, because its lens is in the sulcus, the haptics are somewhere fixed up in the ciliary body or this thing. The bag is not too much under pressure. Somehow I am obsessed with retaining the bag. Somebody would have gone straight away and done a scleral glue diol or something like that. But somehow I did it this way.
দুটো তিনটে কোয়েশ্চেন,
ভেরি ডিফিকাল্ট কোয়েশ্চেনস।
এক নম্বর হচ্ছে ওরকম ড্যাংলিং লেন্সে তুই ওটাকে তুলে ক্যাপসুলার হুক দিয়ে ফিক্স করে সিটিআর বসিয়ে সিটিআর সেগমেন্ট বসিয়ে তারপরে স্ক্লেরাল ফিক্সেশন করলি কেন?
না, scleral fixation of the bag and placement of IOL in the sulcus.
So wouldn't have been better if you do a scleral fixation?
করলেই হয়, আমি তো বললাম, so if somebody is doing a glue dial, I have no problem with that.
You are a fantastic surgeon. I certify everything. But
I believe that there is a partition maintaining the anterior chamber.
How many cases you have seen the
wrinkling?
Second হচ্ছে back.
With the CTR in place, there is not so much of wrinkling of the back because CTR maintains it in a taut state.
Did you face early PCO in these cases?
Yes, PCO will be there. PCO is likely to be there.
Because the lens is preventing somewhat
PCO can definitely be there, but that should not be an issue because lens is supported in the sulcus, and after that time some fibrosis sets in hither and thither that maintains the lens in its position.
ব্যাটসম্যানের রিভার্স সুইপ মারা অভ্যেস আছে না?
Speaker is another very experienced surgeon, anterior chamber surge control, Dr. Deepa Shaha, Adea Eye Clinic.
A very good morning to all of you. Today only one introduction we should give. We want justice. Throughout the environment, only the negativity is there, but we should be a positive, because a positive attitude gives you a power over your circumstances instead of your circumstances having the power over you. So my case is anterior segment surge control. This is a case of diabetic cataract with grade 3 nucleus, adequately dilated pupil. Now when I started the case, it seems to be very easy, but gradually as it progresses, it becomes more and more difficult. So after staining the anterior capsule, I started the Rexis. The Rexis was uneventful. It was of adequate size, near about 5.5. Then I did the side port, the main incision with the keratomes. After proper hydrodissection, I tried to do the rotation. The rotation was also very good. Then I started trenching. My parameters was like this. It was a little bit leathery cataract, so I tried to separate it with the two dialers. I separate it in one pole, rotate the nucleus, and try to separate the other pole. Now I started chopping and see what happens. So there is a surge. My parameters, aspiration was 25, vacuum 480, IOP was 70. So I was confused what to do. It was a Centurion machine, and it was my third case in the Centurion machine. So second time when I started again chopping, again there was a surge. I don't know what should I do. Put the viscoelastic, increases my main port, I thought. So there is a disparity between the phaco sleeve. Try to separate the nucleus again, rotate the nucleus so that there is a free movement. You notice I have changed the sleeve also, but when I again started chopping, again there was a surge. So yes, so it was very much confusing, but anyhow, with the viscoelastics, the nuclear matter, I take out in the anterior chamber, try to complete the case, but you see what happens after so many times of surge, the integrity of iris was lost, and see after some time the iris starts prolapsing and the case becomes more and more difficult. So anyhow, I tried to manage the case. The PC was intact, thank God. Put the IOL and complete the case. After 2 weeks, the patient was quite good, but till 2 weeks there was reaction. But after 3rd week, she gained the vision of 6/9. Okay. IOP was increased, so it was my 3rd case in Centurion machine, sir. No, it was 70 initially. So now, after so many times, I keep my IOP at 40. I won't go with the 70, but I don't know why it happened.
Deepa, I think right from the beginning, I think you should have put in a CTR.
CTR?
Because I tell you, the nucleus, when go to the initial part of the video, just the initial part,
sir.
when you did
Yeah.
the first phaco. You see the bag was rotating. Just see, just this.
So before this?
Just after this, when you go, do the phaco first, you see, the CTR would have stabilized the bag. This surge cannot happen in a Centurion machine. It's out of the question. In a higher end machine, the surge cannot be there. I think the bag was floppy, and if you had put some CTR, it would have stabilized.
But I don't have such feelings, sir. Mani, that's if the bag I was
Just
getting
see
any
the initial
difficulty. এটা একটা stop করব? Before this?
Once you started doing the phaco.
Yes, sir. It's coming. Just wait.
Just the first back. Now you watch. এতটা ব্যাগ বেরিয়ে এসেছে দেখছো?
Okay, so normal HPMC, that's what this was. But I didn't till understand what is the reason. So good machine, but it made me so difficult. So maybe the because of the high IOP. So what does the house suggest? The IOP, this I made 2.8. No, so yeah, I made mistake. Initially it was 2.2. Then I thought maybe the incision is tight. I increases the main wound. So then I thought it was a leakage. So I again changed the sleeve. You see, and the yeah, before that, so I thought ki my sleeve is getting constricted. Initially it was 2.2, then I increase it. Then I thought if there is leakage, I change the sleeve again. So till now I don't know why this surge happened. So whatever it is, so maybe there is imbalance between the irrigation, aspiration and leakage. So we should
ইরিগেশন অবস্ট্রাকশন যেটা স্যার বলতে চাইছেন ইরিগেশন আচ্ছা বাইরে চলে আসছে জল
But when I change the sleeve also, same thing happened. No, sir, then again surge happened. If you go with the video, 3 times surge happened. Okay.
Did you manage to finish the case?
Yes, yes, yes. Yes. But there was a iris prolapse and all these things. Some reaction was there, but I managed. And the good thing is the patient did the second eye also with me. No, sir, I have one question. So now I am using Centurion regularly for 4-5 years. Now I didn't get any surge. But is this the reason I was working initially with 70 IOP? What the assistant stated it, that was my 3rd case in Centurion. Now I work with the 40. So is maybe the reason? No, never. Okay.
Our next speaker is Tanushri. We all know Tanushri is a excellent surgeon, very good speaker, always smiling, and belongs to this district as she practices here. So all over to Tanushri. Yes, of course, and very much to SWB.
Yes, once a month I go to Tripura, but I strongly belong to Hooghly district. আমার বাবার বাড়ি হচ্ছে কাবলে বলে একটা জায়গায় চাপাডাঙ্গা পেরিয়ে, তো ওটা আমাদের নিজেদের বাড়ি। I was born in Howrah and I got married, বিয়ে হয়ে আমি উত্তরপাড়ায় আসি। তারপর আমি শেওড়াফুলি দিশায় কাজ করি, তারপর আমি সান্যাল স্যারের ওখানে শ্রীরামপুরে যেতাম, তারপর ডানকুনিতে এখন নিজের হসপিটাল। তো আমি সামহাও হুগলি যেটা ছেড়ে বেরিয়ে উঠতে পারিনি। থাকি সল্টলেকে, হ্যাঁ, কিন্তু দিনে ডানকুনিতে থাকি, রাত্রিরে সল্টলেকে থাকি। দিনে ডানকুনি, রাতে সল্টলেক। Okay, so it's a sponsored talk, role of moxidecsa fixed dose combination in post-cataract pain and inflammation management. This is a disclaimer. Increasing cataract surgeries in India. A cataract, first of all, is the most common surgery which is performed in human body, and cataract is the most common cause of preventable blindness in our country and all over the world. So there's an always elimination of this preventable blindness. There's always, we aim at more cataract surgeries. With increasing cataract surgeries in India, blindness has come down, you can see in this graph, and the surgery rate has increased. So the most common medical complications are 2. First is the infection, which is a deadly combination, and next is the inflammation. So today we'll talk on the inflammation part. The early complications of post-operative inflammation is the posterior synechia, pupillary block, and acute rise of pressure, which happens in 4.7% of the cases, and late complications of inflammation are posterior capsular opacity and cystoid macular edema. The peak signs of symptoms of inflammation are seen in 2 weeks of surgery. topical anti-inflammatory treatment after modern cataract surgery, that is phacoemulsification, alleviates the inflammatory response and the possible risk of complications such as corneal damage and cystoid macular edema. Corticosteroids or NSAIDs. Corticosteroids are definitely the mainstay of treatment, wider range of activity as compared to NSAIDs, and it reduces inflammation at multiple points in the inflammatory cascade. The rate reduce inflammatory symptoms with dexamethasone, which is the talk of today. Rate of patients with inflammatory symptoms like ciliary flush, pain, photophobia during the first post-operative month, on the third day, 8th day, 2 weeks and 1 month. Dexamethasone and diclofenac sodium. It has been seen that with dexamethasone, the rate of inflammation is much lesser. There is a comparison between the prednisolone acetate and dexamethasone, and here they have conducted the study, and it has they are saying that lesser anti-inflammatory potency prednisolone has one, whereas dexamethasone has a better anti-inflammatory action. So there's a longer duration of anti-inflammatory effect with dexamethasone. So now combating infections and inflammations together. Moxi and Dexa, moxifloxacin 0.5% and dexamethasone 0.1%. To prevent the post-surgical ocular inflammation and infection, the dose, like we give, it's 4 times a day, 1 day before the surgery, and then after the surgery till 15 days. The safety and the efficacy of combined Moxi and Dexa eye drops in prophylaxis after cataract surgery. So there was a study, I'm not going into the details of the methodology, they all went phacoemulsification, and there was, they graded the patient with the AC reaction, pain, and dilated fundus examination. And the AC reaction, the first post-op day, by 7 post-op day and 15 post-op day, it was significantly much lesser. Ocular pain, again, was significantly much less from the first to 15th day. And the IOP was also, there was a spike of IOP rise in the first 1 day, which came back to normal by the 15th day. The fixed dose combination of Moxi and Dexa was found to be effective in preventing the infection and minimizing inflammation following cataract surgery. And the fixed dose combinations are advantageous in developing countries. Thank you.
Thank you, Tanushree. Is there anyone to discuss or pass any comment on this? Okay, thank you. With that, we come to the end of this session. And next is our cataract session. 2 of our speakers are absent, so we finished off early, Dr. Rupak Bishwas and Dr. Abhijit Chattopadhyay. In our next session, session. So in the next session, we have Dr. Pinaki Nag as our moderator, and I call upon the chairpersons, Dr. Arup Chakraborty and Dr. Parag Mukhopadhyay, to be in the front row. The key opinion leaders, Dr. M.K. Ghosh, Dr. Shamanto, Dr. Vijay Banerjee, I think sir has not come, Dr. Ananto Banerjee, Dr. Sunil Surana, Sunil, Dr. Sunil Surana, please. And the panelists are Dr. Shomnath Das, Dr. Nisha, Dr. Amitav Kundu, Dr. Debashish Datto. And the first, sir, would you like to speak first, sir? We start on with a topic. I hand over the mic to Dr. Pinaki Nag for calling the speakers.
Good morning, everyone. Our first speaker is Dr. Arup Chakraborty. You all know him very well. He was one of the best teacher, mentor, and you know he has already a big setup, the Amulya Jyoti Eye Foundation. He's a very good surgeon, and we learned a lot from him. So now we're going to see something else new again from him. Thank you. Arup, is yours now.
Good morning. It's still morning. Thank you, everybody. Now, hypermature cataract, I think everybody will face in their routine day-to-day surgery. And tackling hypermature cataract is always a very difficult, very challenging thing for doing a routine cataract. The challenges are, first is the high intralentricular pressure, and because of the high ventricular pressure, the challenge is really in doing a rhexis. So what you need to do is a good, complete and adequate capsular rhexis. That is the mainstay. Hydrodissection very gentle because you don't know what is behind, and sometimes you may not need any hydrodissection at all, and you may land up into a very small and sometimes a very hard cataract, hard nucleus. Just a few videos I'll show you. This is one of my video which is probably more than 10 years old. It's just I had an Argentinian sign. Now this is a very difficult thing what to do. একটু লাইটটা সুইচ অফ একটা দুটো বন্ধ করি তো পারবে
Anyone from কিচেন সূত্র কেউ আসবেন এদিকে লাইটটা বন্ধ করে দেবেন সামনের
Is it visible? Yes, sir. Okay, then it's okay. So what you do is now what I did at that time, it was a pretty old video. So I had to extend it so that make that into a rhexis light of thing, because the two sides of it you don't know how far it has gone. So doing a phaco in this situation is a little difficult and little challenging also. So I then did a lower part of the rhexis I completed, and the upper part with a cystitome I made an incision on the capsule, and with a capsular rhexis forceps I completed the superior part of the rhexis. So on the two sides, you can see this side and this side, we don't know what is behind. So doing a phaco in this thing you have to reduce your parameters as much as possible, and reduce your, instead of doing too much of sculpting and all, try to do a direct chop. These are certain things which you have to do not to give too much pressure on the posterior capsule. So now I did it, and I'm going to just fast forward it a bit, because I tried to do a direct chop very slowly. And see, it was not so very hard, and the CD is also not very high. I've just used only 8 point nearly 9. The CD is about 9. I'm doing it slowly. The most important thing is that you don't disturb the posterior capsule. There should not be any extension. And so I had to extend forward kore dicchi. Now I could complete the phaco without any problem, and putting in there was a big haptics, the Rayner model lens. So that also is an issue if you have a multi-piece lens or a single piece lens where the haptics is small. It is easy to put in, and with a Rayner model lens, it occupies lot of space, and getting the proper area to where to put in, rather than the leading haptics goes away. So putting it very slowly, and I could manage. Now this is a thing which Argentinian sign many of you may get in your routine cases, especially in hypermature cataract. So how to avoid this Argentinian sign I will show in my next video also. So putting in the leading haptics slowly. One haptics is going, yes, it has gone. Now this is another video. This is also hypermature cataract. Here I could make out that probably the intralentricular pressure is not so high by the look of the nucleus, the cataract. So as a routine, I did not give any, just put the dye and just went straight ahead with the rhexis. What I did was, since the pupil was not well dilated and it was a very, very hard cataract, behind the white matter what you see was a very, very hard cataract. Sorry. It was a very hard cataract anyway. So what I did was that making the rhexis slightly bigger, and so that I can get a proper area to do the phaco. Now I'm not showing the phaco in this case because it was slightly difficult, but I could manage it. But what happened, because it was so hard, there was a small nucleus and an epinucleus which was creating problem, which if I had to do phaco at this time, I was sure I am going to damage the posterior capsule. So I did the technique which Amar Agarwal has said. So I did put the lens first, and there was hardly any cortical matter. So I put the lens first, and after putting the lens, put a viscoelastic behind and over the nuclear material so that you don't disturb the posterior capsule, the lens, and the integrity of the cornea. And taking out this piece was very easy. The next case, this was a hypermature cataract. I knew that the intralentricular pressure was high, so I used my good friend Dr. Pinaki Nag's way of doing taking out the cortical matter. So I first put in a 24 gauge, sometimes I use 26 gauge needle, and aspirate the whatever way. Earlier I used to drain out the cortical matter towards the periphery, but I think this method also works very well. Now here the problem will come later. I could do the rhexis, and you see the cataract was white initially, now it has become black. You will see the actual color now. See, it's a hard cataract and a very small nucleus. These small nucleus have a problem because you are not able to hold it well. Now you see, I did not do any hydro in this case because the lens was totally separated from the cortical matter nucleus. So you can see I can rotate the nucleus without. Okay. Now holding the lens, just see, it will rotate inside the bag, and once it rotates you can't get a grip. This machine, the earlier surgery were done by Infinity and Centurion, but this is the Hooghly machine. It's a fantastic machine to do a hard cataract. And it's beautiful to do a hard cataract, a direct chop if you want. So you have to stabilize the lens with the side port. পাওয়ার স্ট্যান্ডার্ড আমাদের বোধহয় 60-তে করা হয়, ম্যাডাম, কিছু না। ওটা স্ট্যান্ডার্ড আমাদের। দিস ওটলি মেশিন আই কিপ আ স্ট্যান্ডার্ড পাওয়ার ফর সফট, হার্ড, হোয়াট এভার। I don't use anything. The bottle is same. Everything is same. See, the lens is rotating and you can't get a grip of it. If you have to hold the nucleus is rotating. Now, once you get it, একটা chop, if you can do one chop, then it's done. Now, see the way this machine eats up the nucleus. It's a fantastic. If this piece comes out and the chamber is absolutely stable, absolutely stable. These are the situations where you can have a chance of PCR. This is a very difficult part. See how the nucleus is coming out? Makhoner moton, it's just coming out like a. And the next day I tell you the cornea was absolutely clear. Thank you so much.
Thank you, Arupda. We have again seen your fantastic surgeries, and may I ask any of the key opinion persons to give their view whether it could be done differently or any other point to mention here?
Bevel down, yeah. That's a very good technique, yes. But what happens, once if you cannot, if the nucleus rotates, it is very difficult.
A few points I would like to mention here.
Now, one thing I want to tell you, see, if you want to do, if you need to hold a nucleus, what you need to do is get into the nucleus. To get into the nucleus, you have to eat a bit of the nucleus. And once it is rotating, it is very difficult. You can't eat up. It's rotating continuously.
You try. I have tried, I have done, I do it.
Maybe, yeah.
I do it.
And may I just raise a few points for the last case. In this situation where the nucleus is very hard and very small, which rotates, every time I would rather fill the bag with the visco, so that with the bag filled with viscose, the mobility of the nucleus gets restricted. Number one. Number two, in this situation I will use a very sharp pointed chopper. Very sharp, where I normally don't all cases.
I tell you, if you have seen my chopper, it was a very sharp chopper.
Pointed, so that as soon as you just get a whatever hole, you just dig that chopper right into that cortex. So a very sharp point chopper would make the life easier in this situation. And obviously, what I gathered, again, in front of the nucleus you put visco, but also behind the nucleus, so that the legs or the mobility of that part of the nucleus gets restricted, so that you get better hold. That too, I think, it makes it easier.
কিন্তু হ্যাঁ, এটা ঠিক, কিন্তু যেখানে ব্যাপারটা হচ্ছে when you are going and drawing the fluid so fast, ও ভিস্কো তো ফাট করে বের করে দেবে, ও বের করতে সময় লাগবে না। Anyway,
I will just tell 2 lines on Rexis. In Rangachari session in AIFC, Dr. Rajendra Prasad, a Delhi surgeon, he competed with a special technique, sieving needle Rexis. Then all the needles, whatever may be the gauge, 30 or 26, every needle is beveled. When it touches, then Argentinian flag sign develops. So he made sieving needle with Maharshi Maharaj selai kore, kon beveling nei. He made such needle and he did multiple punctures and gradually extended the Rexis. That is a sieving needle, and that got back. No. Bevel Next, what Samuel is telling, another point, it is also I secured from the All India conference, that one speaker told, just keep the blue for a longer period. It pigments the entire capsule, makes it thicker, and then the rexes do not go out. These are
What
2 points.
I do, and honestly, for last say 5-6 years, I have got only one loss of Rexis Argentine flag. As already Aruda mentioned, I normally do the Rexis with first try with the 26, with the not 26 gauge, with the 23 or 24 gauge needle. The reason being, and also go bevel down, so that I can put every single beats has got a reasoning. I tried all sort of Feco chop and all sort of, started, nothing worked. But with the 26 gauge needle, with the 23 or 24 gauge needle, because the 26 gauge needle sometimes get blocked. When you try to pull up the cortex, it gets blocked. So it doesn't suck the loose material always, it gets blocked. So 23 or 24, bevel down, don't sort of nick it right in the middle, just slightly before you reach the middle point, do it, and definitely use a glass syringe, 2 ml glass syringe, and I usually do the same trypan blue syringe I use because it's very loose. If you try with the disposable syringe, it's not that loose. So as the idea is, you enter, before you puncture, you start sucking. You start sucking before you actually puncture. As soon as you puncture, when the heat, at the simultaneously it tries to get out. So you already started sucking. So once you get inside, you already suck some of it. So the tightness or the intralenticular volume gets started losing. And also after you suck, then you tap the nucleus a few times with the needle down. I had quite a few videos of that. Tap the needle down so that whatever the loose material from outside gets actually in the center and you can suck most of it. Then you don't have to do the smaller rexes, you just carry on and it will make life easier. Only one case I lost it because I thought I have made enough suction, but there are few pockets where it was actually raised. I didn't do enough of this tapping and tried to clear it up. So at one point there was a localized raised pressure. That point it just went away. So this is a few points I learned over the years. Use a 23 or 24 needle, use a glass syringe, and make sure either you put some fluid in it already, or you can use the trypan blue so that it's very loose. Start sucking before you hit the capsule, and also then you just as much as possible get the loose material out by tapping the nucleus a few times.
I just want to add one of more points. One is, as much as viscose you want to use, especially viscose, sometimes it is difficult to do a rexis. But with Hyaluron or Hyaluron GB, if it is available, Hyaluron is also now good, it's available. So that pushes the capsule slightly down. So it gets like this. It was like this, and with the pressure of the visco, at least the central part, you put it down so that the milky fluid goes to the periphery. Next is you do a small rexis, baby rexis. And without doing an hydro, you can rotate the nucleus with a chopper or Sinskey hook inside that bag. So that breaks all the locules. Because sometimes there is equatorial adhesion. What is happening in the anterior capsule, the same thing happens in the posterior capsule also. There is a bulge in the posterior capsule also because of the milky fluid. So if you do a rotation, so all these loculi and all these adhesions are broken. So the milky fluid easily can be drawn out. Then you extend the rexis. This is a double circular capsular rexis. Initially it was proposed in Japan, but it is now very helpful for hypermature or Morgagnian cataracts. In spite of that, sometimes you get, and with an utrata it is more easy for me to control rather than a needle. And whatever may be the thing, the capsule which is very tense, you are not sure whether it will give an Argentinian flag sign or not. But most of the time, if you push the capsule little back, the bulge of the capsule little back and the fluid to the periphery by visco, you are successful in creating a round rexis, small rexis. This is the point.
Anybody else want to ask anything else? And I have got one last question to Arubda. In your first case, where there was a Argentine flag sign, if you are not doing it in your own setup where there is a VR facility, would you in every case go ahead to do the phaco in that situation?
Because I have done at least, it was done, it is a 2013 film, and I had one earlier in 2010-11 or so. That video I didn't have. That also I did the same technique, and after that I had 2 or 3 cases as far as I remember, and all these cases I did with the same technique and nothing happened. Nothing happened. It doesn't, actually what happens, it doesn't go beyond the equator. That is the thing. We are worried it is going, but it doesn't go.
Okay, thank you.
Yeah, you have to, as I told you, you have to keep your parameters low. Absolutely.
Okay, thank you, Arada. Our next speaker is none other than the organizer. She is one of the most prominent face in OSWE from Hooghly district. You all know her, so I don't have to give any other introduction for her. So she is going to talk about the IFIS, which we all come across at this age of this term solution.
Thank you so much for the kind introduction, the most prominent face, etc. And self-introduction, sir, ঘরের মেয়ের introduction হয় না। আমার মনে হয় এখন এই মুহূর্তে সবাই আমাকে চেনে, খারাপ, ভালো, famous, infamous, দুষ্টুমি করা, whatever. Anyway, although we are not in the mood of studies that, but still, life has to go on. We do demand justice. Now, this is a topic which I think all of us have faced. Maybe last few years back, it came up very much, and now I think most of us, rather all of us, are facing it in our day-to-day practice. Intraoperative floppy iris syndrome, anything that I'm going to talk about, the devices at all, I have no financial interest in anything that I'm going to show. So what is it? Basically, it is a intraoperative floppy iris is a variant of the small pupil syndrome. It has been observed during cataract surgery in some patients currently or previously treated with the alpha-1 adrenoceptor antagonist tamsulosin. But I will tell you, this was first described by Chang et al., but I would tell you that we do not only find male patients with IFIS. In today's a lot of drugs are being introduced. In today's practice, we find that even females are having a lot of IFIS when we are operating on them. Due to urinary incontinence, I think they are using some drugs due to which some patients, even if they do not tell us the history, we do face IFIS when we are operating on them. This was a case that today, with the case that I'm going to describe, was of a male. This is an old case that I'm going to tell you, where I was not ready. Although the theater was equipped with all instruments, but I was not ready because this patient had an uneventful surgery in the other eye, although he had diabetes, hypertension, operated for prostate, and I was a bit younger, so I was not expecting much, good dilatation. So this was what it was, with unexpected IFIS, good dilated pupil. I think this is a good dilatation, although not full dilatation, not a very hard cataract. So I went on. I usually stain the anterior capsule with blue. So this is what. But as I was trying to remove the blue, put in viscoelastics, and this is what I noticed. The pupil was not only going down, but also it was trying to peak towards the entry wound. So my first thought was maybe the IOP was high because there was a bit of glaucoma which was controlled. The first mistake I did was this. So I tried to repose it through the same wound and the pupil went down furthermore. Okay, so the next mistake, I was wondering what to do. So now sometimes this also happens nowadays. You may choose another site. because that site may be leaky, or the wound may not be as you expected, the valve may be bad. But here, through the main wound, again there is a leak. So now it was quite obvious there was some type of a floppy iris. And again, second mistake, which I don't do nowadays, but this I did. I loosened up the speculum, tried to find out. Sometimes there's a hard eye, because in the moment, in that hurry, sometimes what you do is, I'll just go back a bit, you push in lots of viscoelastics. So what happens, you end up with a aqueous misdirection or a hard eye. So that is what I would like to impress. So this was another mistake, that we usually don't push viscoelastic so much so that your eye gets hard. Or if you do, so you massage a bit on the outside to take it out. So now what to do? Next what? When you have a floppy iris, first is maintaining mydriasis. Second is restraining the iris from prolapsing during cataract surgery. These are the two targets that we actually face when we are having an IFIS. And this is what I have been facing with a shallow anterior chamber. This is the correct way of repositing. So this is what you go through the side port, reposit the main wound. And I would like to show you some of the problems why we would face in we would face in a IFIS. This is whatever instruments you are introducing, and whenever you're going to with the phaco probe, you always injure the iris. So because of the anterior chamber fluctuations, flaccid iris, there's a prolapse. So ideally, we go for a pupil expander in these cases. Although here, in this type of dilatation, we might not need a pupil dilator, but in case of IFIS, it is a must, because otherwise your iris will get traumatized so badly that even after a good surgery, and anyway, the surgery will not go uneventful. So I prefer to have 4 hooks, because I've already burnt my fingers with 5 hooks. I'll tell you why. I'll take few seconds or maybe 1 minute more, because one of the speakers is absent, so I'll take that advantage. So, so now I just want to press on this, that in these cases, what I would say, I have burned my hands with 5 hooks, because when we put 1 hook, we ideally say that 5 hooks is the best. One is sub-incisional. But in case of a IFIS, first of all, it is already good dilatation can be achieved with 4 hooks, number 1 point. Number 2, in a flaccid iris, if you put a sub-incisional hook, there is high chance that with that unstable anterior chamber, it will be very difficult for you to go with the phaco probe. You will go and hit the iris surrounding. So that is better. You don't use the 5th sub-incisional hook, because with 4 hooks, the job is quite well done. So this is it. Now, certain things that we need to remember, even if we are using hooks to expand and go on with a surgery, this is the next problem that you face. Loose hook. A hook comes out if you have too much turbulence. As I'm telling you, this is an old video, but I tried to collect 2-3 videos and put in the problems here, because if there is turbulence, there's high chance, since the iris is flaccid, that the hook will get dislodged. So please look out for that, otherwise you will end up in trouble while doing phaco. So you have to keep your infusion under control with good fluidic Centurion machine. Everything is quite well if you can control. So reinsert the hook, wash off your cortex very well, and everything can be done as it is. I use a spatula. This I wanted to show very much. I usually use a spatula when I'm putting my phaco probe in, or I'm putting my injector in, whenever there is a flaccid iris. This helps to protect my sub-incisional iris. So this is one thing I would like to share. This is good. Over the time, I've got good results. And the rest of the surgery, I think, is just routine, because there's not much difficulty. One thing I would again like to press at the end, that please remove the hooks very carefully in the opposite direction. Don't hurry, because already your iris is a bit damaged if you are not careful from the beginning. So again, if you injure it, you might get an atonic iris. So be very, very careful while you are removing the hooks, and especially the direction in which you are moving. So it is usually in the opposite to the direction of insertion. So that's it. We might use another device. I prefer hooks and also BHEX, especially if your anterior chamber is shallow. There's nothing like that like BHEX. It gives a much cleaner iris margin after surgery rather than hooks, which sometimes might be rugged So, of course, you do a better surgery when you are using a BHEX. Dilatation is optimum. So, that's the option. So, the take-home message is plan preoperatively, judge the case at the offset and plan accordingly. Sometimes you might have a positive history, you might not have a positive history, as I said. In this case, I did not have. Good fluidics, avoid turbulence to minimize trauma to the tissues, use minimum manipulation. And thank you all for kind hearing and attending this conference. Thank you.
Thank you, Sudipta. We have seen again your brilliant surgery. Now, any of the key opinion leaders, would you have some of that, please?
Yes, sir.
With the BXR or the IRISO? You. In topic case only.
Sir, if I'm operating in Hooghly, I use hooks because I cannot afford BHEX in all the patients. I do not charge the patient for this. But if I'm operating in Kolkata in certain hospitals, then I use BHEX. Both of them are quite comfortable if somebody is using it regularly. BHEX is very good.
I'm not asking about the small people. I am
In
particularly
IFIS? In IFIS?
Only not. I am asking about the small people, but only
IFIS.
the
IFIS.
floppy iris.
IFIS, yes sir. Yes sir, both of them they do good, but I will tell you, if there is the AC depth is usually fluctuating in case of IFIS, but if you have a shallow AC, it is good to use a BHEX rather than a hook. But hooks is universal.
Any opinion?
Hook is universal.
For my experience, I feel for floppy iris who are on tamsulosin, BX ring is better. But if it's a rigid people, then it is better for any other reason. Atonic people, rigid people, then the iris looks better. The reason being, in floppy iris, if you put 4 hooks, sometime where there is a bigger gap, and if your side port or the incision is there, it still keeps bunging and keeps prolapsing. But the BHEX ring, the way it is designed, it can actually hold it in place, and it doesn't tear the capsular, the iris margins, and that makes it in position, and post-operatively also it looks good. So for floppy iris, for tamsulosin related, it's better to use BHEX ring than the iris hooks. But in other tonic people, it is better to use the iris hooks than the BHEX. And in another thing, like in the first case, if you would have known beforehand that patient is on tamsulosin on the clinic, what I feel, if anybody on the tamsulosin or this kind of drug, if I see their people not dilating more than 5 millimeter, to start with I'll put a ring or whatever. But I don't actually start and then see whether if it is less than 4 millimeter, I start straight away because that saves so much of hassle. Many people say when it is needed, you put it. But in this situation where there is a already history and you see it's not dilating more than 4 millimeter in the clinic, is straight away I put the ring in. Anybody else different? Anybody else
feel iris hook dilates more. If we need more dilatation, iris hook is better.
The patient was on tamsulosin. This was the mistake that I did, that this patient was on tamsulosin 20 years
3
back.
months. I think sort of the ones presented is just 3 months. If somebody is on tamsulosin, that makes the iris floppy. So if they have stopped it 1 year ago, see, it doesn't matter. It's still the
Pinaki, one thing, Pinaki, just when what you said that, see, the floppy iris you can diagnose only on the table. You cannot diagnose elsewhere. Now, when you are seeing a small people, say 4 millimeter people, if I see that I can do a rexis of 4 to 4.5 with a 4 millimeter pupil, I would do without any dilating agents. What I want to say that floppy iris you can only diagnose when you are putting in the phaco probe. Before that, diagnosing a floppy iris is not possible. So what happens if I see a pupil size of 4 millimeter, as you said?
I said if they are on, they are on tamsulosin.
No. Still I am telling you. Tamsulosin the patient is on tamsulosin. There are patients who have a full dilated pupil and a full phaco done without there is any floppiness.
That's what I'm saying. That's exactly what I said. If somebody is on tamsulosin, that doesn't
Yes.
The thing you'll see
No, what you said, again I'm saying, if the patient is on tamsulosin and the pupil size is 4 millimeter, I will still not use a dilating agent. I will still do it because you don't know the reaction. If there are the floppiness, the pupil isn't dilated because then the patient may be diabetic, there may be some other reasons for the pupil doesn't dilate, but floppiness of the pupil you can only feel when you are inside. So one need to see the patient is on tamsulosin and a 4 millimeter, you go ahead. If you can, you are success. If you think that you can do a good Rexis, you go ahead. You can manage. I have seen you can manage it. But if during surgery you find problem, then you have to do it.
By that time you find problem, there is already
No. এই যে প্রবলেমটা ওর হয়েছিল, what problem she showed, this is an old video. Now she had learned. If she sees this one iris coming out during pushing the visco, ও এখন আর wait করবে না. She will put that she didn't know at that time. She made a mistake. Now she will not make a mistake because আমি visco ঢোকাতে গিয়ে iris বেরিয়ে আসছে, ও guess gone. ওই wound দিয়ে আমি যাই করতে যাব, ও iris বেরোবেই। হ্যাঁ, ও তখন জানতো না, এখন জেনে গেছে, এখন কিন্তু ওই জিনিসটা করবে না। না ট্যামসিলোসিনে আমি দেখেছি পেশেন্টরে কিছু হয় না, একদম পিপল ফুললি ডাইলেটেড, নো there is no floppiness, nothing. তারপরে কিছু থাকে পিপল ছোট, পিপল ক্যান বি ছোট ফর মেনি রিজনস, ইটস নট বিকজ অফ দি ট্যামসিলোসিন. So there you see কিছুই হচ্ছে না, nothing happens during the surgery, nothing has happened.
Sir, whenever you make a port, there is a fluctuation in the AC. If you see the iris is moving a bit unnaturally, you can, and if there is a history, you can anticipate.
Understand means এই কেসটা যেটা দেখালো, এটা তো ফেকোপোপ ঢোকানোর আগে ওই আইডি ও ভিস্কো ঢুকিয়েছে, তাতেই বেরিয়ে চলে এসেছে.
When she made a main port, there is a meiosis, sudden meiosis.
I wanted to show the mistakes.
One more thing that I have experienced, that regarding iris hooks, when you go for iris hooks particularly in case of floppy iris syndrome, I have seen that using 5 hooks makes a much more difference than using 4 hooks. If you make a pentagonal structure, the interval between the 2 hooks is much reduced, and therefore the floppiness,
You're supposed to put sub-incisional, right?
not exactly.
At the channel never, because when you are putting the ফেকোটা ঢোকাচ্ছো, ওটা বেরিয়েই আসবে.
Ma'am, when I put the sub-incisional hook, I usually go through sclera a bit, 1 millimeter in the sclera, and it keeps a margin.
আরেকটা জিনিস যেটা হচ্ছে, in case Sudipta, if you find that from the main wound visco is coming or in a floppy iris, always use a Helon or sodium hyaluronate on the iris so that iris এর মুভমেন্টটা একটু কমে যায়.
So other than tamsulosin also, I have noticed most of the females, those who are in anti-neurotic drugs, they also have this things or intraoperative floppy iris. Have anyone noticed this things?
Yes.
Okay, our next speaker Sugata couldn't make it, so we'll jump on to next one. Is Shivashish Das, the young bright chap of OSWB now. He is a very good surgeon, so we're going to see what he is now going to say.
Good afternoon, everyone. So today the topic given to me by Sudipta Di was managing a posterior polar cataract. Posterior polar cataract is a type of cataract that we should all take with a pinch of salt. In my personal opinion, what I personally do is, when I find a posterior polar cataract, I take all the preventive measures beforehand. Usually in a case of posterior polar cataract, 70% of the time the posterior capsule does not open up. But to be on a safer side, I feel that we should be ready, in our mind, we should be ready that when we are taking away the last pole, the posterior capsule will open up, and whatever we need to do so that we have all the things ready at our hands. So this is a case where fortunately it did not open up, but I'll just discuss the points, what should be done. So what I do follow. I usually make a moderate size Rexis, not a very large Rexis, because if I need to place the lens in the sulcus, do a very gentle hydrodelineation, no hydrodissection, till I get a nice golden ring. just a few shots of fluid to get a good delineated part. Little bit of eating away the nucleus. But in these cases, I do not try to rotate the nucleus forcefully. If it is not rotating, with just a few nudges, if it is not, I'm not getting a proper chop, and or I'm not the soft epinucleus, the soft nucleus is not rotating. At that point, I stop. Just put in a little bit of more viscoelastic. The plane that has been already created for during the hydrodelineation, just repeat that plane again. Put a little bit of viscoelastic to separate that epinucleus from the posterior cortical plate. Now this will make our work much more easier, as the soft epinuclear plate will come out. Minimum manipulation in the bag is what we desire in a case of posterior polar cataract. So here we can see that the soft epinucleus, the nucleus and the epinuclear plate has come out, leaving behind the cortical at the end, the cortical part with the small posterior polar or subcapsular thing that is there. And in all the stages, we should prevent the AC from collapsing. Before taking away the main phaco port, we should fill up the anterior chamber with viscoelastic. While doing a cortical cleanup, usually I try to take away the cortex from all the sides, leaving behind the central part. The central part is what I do at the last, so that even if the posterior capsule opens up, there is the minimum amount of cortex that is left in the AC. But we are fortunate that maximum of the time, in my experience, about 70% of the posterior polars do not open up. But even if it does open up, we can always do a anterior vitrectomy and put a lens in the bag also, or a 3-piece lens in the sulcus. So mainly the points to remember is hydrodelineate, do not hydrodissect, do not try to chop or rotate forcefully. Always maintain the AC at all times. Whenever you are coming out with your instrument, fill up the AC with viscoelastic. Take away the last plate centripetally and be slow and keep calm, and in most of the cases you will end up with a good result in your PPC cases. Thank you.
Thank you, Sivasis. That was a brilliant copybook style surgery. What you're supposed to do, you did all things like copybook style. That's brilliant. Anyone wants to make any comment?
শিবাশিস একটা কন্ট্রাডিক্টরি কথা আই ফিল উইথ মাই এক্সপিরিয়েন্স যে মেক আ স্মল রেক্সিস ইটস আ বুক টিচিং দ্যাট মেক আ স্মল রেক্সিস ইন পিপিসি বাট মেক আ বিগ রেক্সিস doing a phaco in a big rexis is much easier. With a soft lens, hard lens, always is easier. You did a visco separation.
Yes.
That would have been much easier with a larger rexis. And if you make about, say, 5.5, even up to 6, you still have a margin of 2 millimeter to 3 millimeter where you can put a multi-piece lens. So book teaching is make it small, but I personally feel
that was the initial book teaching, because people used to do, if there is a rupture, there will be optic capture. That was the main reason for doing a small. If there is a blowout, then you will do a optic capture. But now it is less and less. And most important thing, I think, as you said, not all the PPCs do blowout. We now have all the gadgets. The anterior segment OCT is one of the most important things you do as routine, where you suspect this is a typical PPC, you get it done, that whether there is a dehiscence in the posterior capsule. Exactly. Exactly. It can.
No, but
if you know.
No, that is what I agree with, sir.
Exactly. I had one patient, I did beautifully, but I put the lens under irrigation. যে ইরিগেশনে দিতে গেছি ওই টেনে নিয়ে ঢুকে গেছে. So always till the last moment, anytime it can rupture. No, no, ও যেটা বলছে, what Devdas, no, what Devdas is saying, I also fully agree. When you feel this is PPC, treat it as a PPC till the end.
Yes. Bad
That
PPC, bad. মানে that
আমার মতে হচ্ছে যদি না ফাটে ওটা পিপিসি ছিল না, না ফাটলে পিপিসি ছিল না।
Dr. Mrinal Ghosh tried to say,
most of the time it is a posterior subcapsular.
Something 3 times. মৃণাল কিছু বলছিলে বারবার, বলো বলো।
না ফাটলে পিপিসি নয়,
বলো।
So no, just listen. No question of bad or good. Most of the PPC which are diagnosed clinically are not pathological PPC. Those who do not rupture are not real PPC. No. Etiopathogenesis of PPC, if you read any Zimmerman or any book, it has to have a rent at the last. If it is not that, your clinical diagnosis was good, but pathologically it was not.
আগে অনেক কথাই বলতে হবে, শেষে বলতে হবে ভালোভাবে হয়ে গেছে।
What is PPC? It is just a poll. It is already a dehiscence. So most of the PPC which are clinically diagnosed, even on OCT, it may not turn out to be pathological PPC. Yes.
Sorry. Topical. It doesn't make a difference. No. Jodi Phate.
No, sir. Sir, but I feel that for the people who are starting out, I think local anesthesia is better because if the patient is under topical and the posterior capsule ruptures and you need a vitrectomy, then the time of surgery increases, the patient will start squeezing, the patient is under discomfort. If the surgeon is not confident that even after a posterior capsular rupture you will be able to complete your surgery in like 15-20 minutes, then it is better you, whatever you are comfortable with, go for a local anesthesia so that it does not end up in a more messful situation.
Okay, thank you, Shivasis. Our next speaker is DDD, isn't it? DDD, Diptesh Das from Disha.
No,
You're not
from Sushruth.
Sorry, from Sushruth. Okay, he's Sushruth. I think she got me wrong. She told me about. Anyway, sorry about that. So Diptesh Das, another young surgeon who is going to DDS. Okay, you go ahead with your presentation. I'm sorry, I was actually given that wrong information.
So my topic is real versus real. What we show in our presentations and in our edited video, and sometimes it deviates from what actually really happens. So I have this routine surgery. There is a bit subluxation, and you can see there is a subluxation, and as per general guideline, we usually follow the CTR protocol that you should do a CTR as late as you can, but as early as you must. So this being a small subluxation, I decided that I should insert the CTR a bit late. I usually follow this protocol of staining the anterior capsule after giving the visco, so that I stain the multiple sides with the blue, so that the blue doesn't go through the subluxation to the posterior to the vitreous cavity. That may hamper the fundal glow. You can see the staining is quite good in this technique, and as it is small subluxation, I proceeded at routine. I do the hydro and did the phaco. A bit fast forwarded video. So the subluxation is fluctuating. I did the phaco, I did some vitrectomy, I placed the, did the vitrectomy, I inflated the bag, I placed a CTR ring, I usually place the CTR ring with a second instrument support, so it doesn't go to the sulcus. This is more forwarded because with the CTR ring the cortex clearing become a bit difficult. And I placed a single piece lens in the back. So you can say that everything went according to the plan as far as I showed in the video. But what really happened? You may have noticed I removed the phaco tip without giving viscose support, and as soon as I removed the phaco tip, and the AC became shallow and vitreous started to prolapse through my main root and through the side port also. You can see this from the side port also, and it was pushing my back forward. So I thought a little bit of vitrectomy will be enough. I proceeded with the vitrectomy, but I was fearful that if I go aggressive, I may injure the back and surgery could not be planned as proceeded at planned. So I was a bit cautious to protect my back. And the vitreous was collapsing more and more. I went to the side port. I was protecting the bag with the irrigation. I thought I did enough. This part was challenging as AC was becoming shallow at this part, and it started to collapsing from the side port again. This back thing, this was making that part of the AC so much shallow, and the bag was also coming out from the main wound. That entering any instrument without risking the tear of the bag was very risky. So I try to scoop the vitreous from the wound with a spatula. Little style always remains. And a little stand icon can see always remains at this near the main port, so I used all available resources. Then again, it is not working as much. Collapsing from both the wounds. So these two wound option are lost to me. So I went with the vitrectomy from the other port. I first go for the side port vitreous, and when it is removed, I support the bag with the vitrectomy and the irrigation port and did a bit aggressive vitrectomy. Now I go for the base of the vitreous strand. Now you can see a bit jerk. You can see the jerk. At the base is cut, the remaining of the vitreous blob came out from the main wound, and I knew from that my vitrectomy is complete. Now I can easily inflate the bag with the piston. So the real differs from the real.
Thank you, Dr. Diptet Das from Susrut. I am sure there will be lots of questions coming. Just before I ask the other people, just one thing I would like to ask you. Why, when you are doing the phaco, after removing 1 or 2 segments, why you didn't consider putting the CTR at that point rather than when you come out after finish? That would have increased the whatever lap succession.
Purpose of showing my video that I should have put the CTR beforehand.
And your title is really appropriate, real and real. That's what we see in real, but actually in real we don't get to see those things. Thank you. And the first question, Debraza. Start.
My fault was to be overconfident that I can manage this to a bit late without putting the CTR ring. What I should have done to put the CTR ring first after doing the rexis. That would have made my surgery easy and put a triamcinolone assisted vitrectomy.
In the second case,
No, same case.
No, in the second case,
Same
case.
Same case.
Edited,
First video I just edited.
What I am saying, that if during you saw the vitreous coming out from the wound and it was increasing, would that help that you put CTR at that time? At that time,
Sir,
when the vitreous
was very shallow and the bag was bulging, you could see, and
yes,
I was
but if you had put it through the side port,
yes,
CTR
but the right hand side part, the bag was a bit shrunken, and I feared that when I move the ring at that part, it might pierce the bag, because it was forcing with so much force, and AC was very shallow.
No, Diptesh, I have a question that
AC was very shallow at that part. That was my fear.
it is a wonderfully what you have done. মানে আমি হলে যেটা একটা জিনিস what I do, if I find a small subluxation, rexis করার পর why not put a capsular hook in that place? After doing the rexis, put a capsular hook, do the phaco. মানে main purpose তোমার ছিল যে I'll put the CTR late. তো ওখানে একটা ক্যাপসুলার হুক দিয়ে যদি আমি ওটাকে টেনে দিই কিছুটা স্টেবিলাইজ হয়ে যায় তো ফেকো করা মানে ইউজুয়ালি হোয়াট আই ডু ইফ আই ফাইন্ড আ স্মল সাবলাক্সেশন বিফোর আই ডু দ্য ফেকো আই পুট আ ক্যাপসুলার হুক দেয়ার then I do the phaco, then I put a CTR.
So the idea is putting a capsular hook rather than a CTR is if I cannot do that successfully and I have not pushed the CTR beforehand. Yeah, but if I put the CTR, yeah.
ওইটা বাড়ে না তাহলে
What I am saying, it is a large subluxation.
Withdrawal of your phaco also will not cause this.
Yeah, absolutely.
Taking out the nucleus and other much easier with the CTR than with the
CTR দিলে অনেক মানে it becomes a little phaco becomes a little difficult if
So if especially the cortical wash. Yeah, that is.
Sir, in these cases, is it better to go for a pars plana approach? মানে that the thing that was মানে একটা তুমি vitrectomy port করে নিচে থেকে pars plana approach এ this problem of this thing coming out bulging out becomes
most of are reluctant to do that, but it is a great help, I think. It will be a great help, I think.
দুটো জিনিস, এক হচ্ছে একটা সুইচার, টেম্পোরারি সুইচার 10-0 মেন পোর্ট, আর 2 নম্বর হচ্ছে আপনি যেভাবে করছিলেন তাতে ভিট্রিয়াস হাইড্রেশন হচ্ছিল প্রচণ্ড। দ্যাট ওয়াজ দ্য মেন কজ অফ দ্য প্রবলেম।
If you go back to the video, video, the way you were doing, that's exactly the point.
So
The
the-
very rightly said, you are hydrating the vitreous with the irrigating thing. It should have been not there. It should have been in different place. When you do the vitrectomy, the hydrating, you are actually directly hydrating the vitreous, which
Yeah.
is called more prolapse of the vitreous.
That's I agree, but I was doing only because I was trying to protect the bag. You can see I am using that instrument to protect the bag.
regarding-
because it is coming to the wound actually.
As because you said you were reluctant to go for a
It is goes directly to the vitreous and is keeping on hydrated.
very well shown. This we have, I think each one of us has gone through this stage, and these are the steps which we take towards perfection. So as you said, you were a little bit reluctant towards going what he suggested, pars plana.
Yeah.
What I would say, you could have the idea of being pars plana, doing is quenching the source of from where the vitreous is coming. So don't do a pars plana if you are not very comfortable. So use the irrigation in the anterior chamber. Don't have the irrigation in the vitreous. Have the irrigation in the anterior chamber and go deep down through your cutter. That will quench the source and act almost as like a pars plana vitrectomy without a cannula, trocar cannula. Thank you.
Okay, if there is no more questions, so we are ending this session. The next session would be very interesting. Saurabh is going to get some quiz done. I think not sponsored. Quiz concert.
Cancel. There will be no entertainment and nothing.
Okay. All right. Okay.
So we cancelled that. Quiz was not on ophthalmology. Quiz was on
Hooghly district.
Hooghly district. So I cancelled that. I didn't prepare it. না না ওভাবে আমি রেডি করলাম না যখন দেখলাম যে এটা হবে কি হবে না ঠিক নেই I was given a sponsored topic, but these slides are not from the company, these are made by me. So myopia prevention and progression and overview. This is very interesting and important topic for today's ophthalmology because many things are coming in myopia management, many things. So first is a significant number of infants are found myopic on non-cycloplegic retinoscopy. However, most of such infants reach emmetropia by 2 to 3 years of age. Whenever you see a child in your clinic, you do a retinoscopy. Even if he comes for some other purpose, do a retinoscopy. If you find the child is slightly hyperopic or emmetropic at 3 years or 3.5 years of age, you can be sure that they may go to myopia at the age of 6, 7, 8. Or if, I'll show you other reasons also. So this is an important, but they are little hyperopic, they will emmetropize at the age of 6, 7, 8. But they are little myopic or little hyperopic, 0.5 hyperopia, they are going to have myopia. Because the influencing factor now coming for this increase in myopia, what is happening. Right, this is one important point. Prevalence of myopia is high in premature birth. Premature babies, please remember that incidence of myopia is high. Increase in preschool age and young adults reaching 20 to 35% in US, more in some parts of Asia. Prevalence decreases with increasing age. As the child grows, if they are not getting myopia, they are not going to get high myopia after that. That is also very important. If they are reaching 12, 13, 14, the emmetropic, they are not going to get high myopia at least. I started my myopic class at class 11. My sister started at class 6. She reached 9, -9, I reached -1, 1.5. So as the child grows, if they are not getting myopia, they are not going to get myopia, high myopia after that. There may be a moderate astigmatism and low myopia. Some studies suggested higher in females than in male myopia. Prevalence increases with higher income level and educational attainment and persons requiring great deal of near work. This has been proven that higher the education level, the child studies more, they are getting more myopia. But now we are getting, I have got a 7-year-old child few years back with 23 or 24 myopia on detection. They are actually pathological genetic prevalence. That is not a childhood myopia of this sort of thing. myopia is 22.9% at present, and high myopia is 2.7%. Estimated to be in 2050, myopia will be almost 50%, and high myopia will be almost 10%. So this is the way the myopia is now prevalent in the world. Possible risk factor for myopia development. Family history of myopia. This is important. Presence of myopia on non-cycloplegic retinoscopy in infancy. If you see a child 3 years of age having some sort of myopia, they are going to get myopia. Decreasing to emmetropia before entry into school. And refractive error of emmetropia or 0.5, what I was mentioning. ATR astigmatism is one of the reasons. Decreased accommodative function or near point esophoria. This is also an important contributing factor. And substantial amount of near work on a regular basis, not going outdoor. Steep corneal curvature or high axial length to corneal radius ratio and less outdoor activities. All are now contributing towards high myopia, development of myopia. So basis of treatments are two: myopia correction, optical contact lens, and myopia control. This is the part where most of the people are now discussing, that control of myopia. Can you prevent myopia? Can you prevent progression of myopia? All these things are important, and pharmaceutical industries have come up with drugs, and that is for after lot of studies. It is not that somebody has told you that put atropine, it will work. But there's lot of studies have gone. I'll mention a few. So optical correction, I'm not going into detail. So problems with currently available treatment option. What are the problems? Undercorrection of myopia. There was a thought once, undercorrect it. Undercorrect the myopia. So does not slow myopia progression. This has been proved by studies. Either increase or has no effect on progression. Bifocal or multifocal spectacles. People have tried PL, progressive addition lenses versus single vision lenses. There is Investigative Journal of Ophthalmology, there is a very good article on that. You can read that. Bifocal or multifocal. Difference in progression rates is typically not very clinically significant. Even if you put a PAL, this is not very clinically significant. Gas permeable contact lens slowed myopia progression, but it is unlikely to be permanent. This is also important. It can reduce for some extent. Yeah, RGP lenses. Corneal reshaping, the orthokeratology. I have no experience. I have spoken to few very senior optometrists also. They also said that in our country, nobody practices orthokeratology, but it is worn overnight, the contact lens, flatten the central cornea and temporarily reduces amount of myopia. This is Ramdev Baba's one exercise also there. They are pushing the cornea for some time, and for some time they see better in low myopia, but that is not a permanent solution. So limited availability in India, as I said, increased risk of microbial keratitis as it is worn overnight, and higher rebound increase in myopic progression. This has been proved that after orthokeratology that there is rebound increase of myopic progression. Soft bifocal contact lens, it is typically worn by some adults, not in children it is suitable. So now it comes the topical pharmaceutical agents and decreasing the myopia progression. This is the hot topic now, and now there is a lot of discussion on percentage of atropine. How much percentage? Is it 0.01% or it is 0.05% or higher strength? So most effective in comparison with other strategies so far. Mainly induce mainly includes anti-muscarinic agent. That is atropine is an anti-muscarinic agent. And these are a class of drugs which blocks the action of acetylcholine at the muscarinic receptor on structures of the eye. That is the mechanism of action. Atropine sulfate has been shown clinically effective in trials. Atropine is the only currently available anticholinergic drug for use in myopia treatment with demonstrated consistent efficacy. This is important, that It is consistent efficacy. Till now, used by clinicians in off-label way of myopia control. It was initially off-label. So basically, atropine was used long back. I was reading literatures, they said it was in almost 30, 40 years back, people used atropine to, there are some surgeons, they use atropine, 1%, of course, there was a lot of. So mechanism of action is myopic eye. There is normal pupillary size and scleral remodeling, scleral matrix, collagen fibers, enzyme and proteoglycan, and axial length elongation. This is the idea behind progression. So what happens with atropine? There is slight increase in pupillary size. So they are more exposed to UV rays, which hardens collagen. This is the theory, it is postulated. So it blocks the axial length elongation because the collagen is slightly hardened. That is the idea. That's why the outdoor activities are important. With the exposure to sunlight, the vitamin D, there is stiffening of collagen, which reduces the increase of the axial length. That's why in Singapore, there are 3 PT class or 2 PT class is compulsory by the Ophthalmological Association to national government. In China, they are putting glass walls in the class so that sunlight can come. So all these things, measures are taken place all over the world. Mechanism 2, what is said that myopic eye, chronic inflammation, weakening of the scleral tissue and scleral elongation. Atropine blocks this chronic inflammation stage and blocks the elongation. This mechanism 3 is slightly complicated. Visual input, initial events into retina. This atropine acts in both these 2 areas. So programs of gene expression, cell proliferation, scleral remodeling, axial length elongation and myopia. All these things that atropine, this is a muscarinic receptor presumed to exert myopia protective effect mainly through muscarinic receptors. Muscarinic receptors found in cornea, iris, ciliary body and ciliary muscles, epithelium and crystalline lenses. Atropine targets biological receptors in retina and sclera to curtail myopia progression. These are all research and theories behind why we use atropine, how it acts. Clinical evidence, first report to use atropine in myopia is as early as 19th century. It is not new. And subsequently, many studies are done to evaluate the effect of topical atropine on myopia progression. Amongst this are notable as ATOM 1, that is atropine treatment of myopia. Atropine in myopia, ATOM 1. Study in Asian children which evaluated atropine 1% eye drops versus placebo and reported that differences in myopia progression between 2 groups was statistically significant, but that was 1% in ATOM 1 study. Although atropine 1% was found to reduce myopic progression, there are several side effects: pupil dilatation, loss of accommodation, photophobia, near vision blur, poor tolerability, dropouts reported in these studies. Because if you give a child of 1% atropine, then definitely it is not tolerable for them, for their, at least in the school age. And therefore, ATOM 1 group then initiated second study in 2012, that is ATOM 2, which compared lower dose of atropine as 0.5% and 0.01%. Clinical evidence, efficacy and safety data from global studies, ATOM 1, then LAMP study. LAMP study is another study, I'll tell you later. ATOMS 2 has divided their studies into phase 1, 2, 3. ATOM 1, I will not going into detail of that atropine 1% and vehicle, and these are the number of children completed 2 years. Efficacy assessment is by change in spherical equivalent refraction as measured by cycloplegic refraction, change in ocular axial length as measured by ultrasonography, safety assessment, occurrence of adverse event. You can use your optical biometers now in all myopia cases to do the axial length on the initial visit, because you are not no need of ultrasound measurements now. If you are an optical biometer, I started doing in few of my educated patient who understands it, that why I am doing it. So I do an optical biometer for this parameter assessment. After atropine, I am doing it again after some time. So what is the rate of elongation? I can have some rough idea. So you can use your optical. You can add something to myopia treatment, just not giving a glass or put this drop. I am also learning that what is happening actually with atropine. So maybe after 2-3 years, I'll be able to give you some more data for that. So this is atom 1. Atom 1, I'm not, okay, these are all details of that. It is discussed in some other forums. Low concentration atropine for myopia progression. This is LAMP study. This is one of the important study. Randomized, placebo-controlled, double mass trial to evaluate the efficacy and safety of low concentration of atropine eye drops, 0.05, 0.025 and 0.01% compared with placebo over 1 year. So this has shown that efficacy assessment was that myopia progression in terms of spherical equivalent changes over 1 year and axial length changes in 1 year is a secondary finding. Primary finding was the spherical equivalent change and axial length change was the secondary finding. What I was just mentioning, that how can you measure it? You do an optical biometry in those cases, keep a data on your case sheet, and next time you do it again. Safety assessment, change in accommodation amplitude, mesopic and photopic pupillary size, side effect, distant visual acuity and near visual acuity, all are the parameters which were measured in these studies. So results of LAMP studies, atropine eye drops of 0.05, 0.025 and 0.01 reduced myopia progression with a concentration dependent response. This was the LAMP study finding. All concentrations were well tolerated without an adverse effect of vision related quality of life. Of 3 concentration used, 0.05 atropine was most effective in controlling spherical equivalent progression and axial length elongation over a period of 1 year. However, effects of rebound myopia post cessation of treatment was not evaluated. Entrode is coming with this concentration. They have not got a DGC approval yet, so they have not come. So these are atoms to study after 5 years, 12, 14 and 16, right? So I'm just not going into detail, it may not be required. So 5-year results. So clinical evidence, efficacy and safety data from Indian studies. These are all other studies. So Indian studies, that Shankara Eye Hospital, Bangalore, they have published it in Asian Journal of Ophthalmology. Baroda Children, Jethani is one of the very important person in India in pediatric ophthalmology and for studies on myopia. Jitendra Jethani, we are good friends, and Kothari also, Mihir Kothari in Bombay. So Jyotirmaya Eye Clinic, they are 3 studies in Indian context of that. So Indian study says that endpoint is changes in spherical equivalent, axial length, near point of accommodation, pupil size, macular thickness, subjective macular thickness, why they're exposing the child in more UV. So that's why they have given a macular thickness study also. Subjective symptoms of glare and photophobia were noted. Systemic side effects documented. So Indian study says that well tolerated, no evidence of any conjunctival congestion or corneal affliction. No systemic side effects were recorded. 5 children had occasional glare to light and 4 children had occasional photophobia, not requiring any treatment. I had a few patients who complained of this problem of photophobia in the morning, but I reassured them and they continued it. One child had progression of 1 diopter over 6 months period, while atropine 0.1% eye drop. So these are the study reports, and lowest concentration of 0.01% atropine seems to retain efficacy in Indian children with darker iris and is a variable concentration of reducing myopia progression in children while being well tolerated. So 0.1% in Indian children is adequate as studied by Indian point. So these are Indian studies again. Endpoints are the axial length, change in spherical equivalent and adverse effect. So atropine in prevention of myopia, there are a lot of studies recommended in ophthalmology journal. These are the Indian expression. Now I'll finish it now. Now I'll come to this, one of the very important aspect now. I have not much of experience with that, but this has come, so I am just telling you, you might get some prescriptions where this has been prescribed. What is peripheral defocus? Peripheral defocus means the eye, the globe is like this. So whatever I am focusing on phobia is not in the same on the peripheral retina, because they are slightly ahead of the phobia. So whenever you are focusing the rays, it is on the phobia you are getting the power, but what happens if the rays falls on the peripheral retina? So that is called peripheral defocus. So this is shown that this is focusing on phobia, and when it is focusing beyond this eyeball, it is the hyperopic focus. Right, this is hyperopic focus. And when it is focused in front of this retina, it is myopic focus. So this is important, that myopic correction with single vision contact lens or single vision spectacles equally corrects myopia on the phobia and the peripheral retina. It is not inequally actually. The myopic eyes, phobia and peripheral retina are in different myopic states. As the eye is elongated, there will be more effect of that. The peripheral retina is more hyperopic, therefore the equal correction peripherally and centrally is likely to enhance myopic progression. This has been studied that if there is a myopic defocus, a hyperopic defocus, then there is a stimulation for elongation up to this. The eye will try to reach that. So that is a purpose of the eye is getting elongated, because of the spectacle is focusing the peripheral retina as hyperopic focus. So the idea behind this, that you see that peripheral defocus is that 30 degree, 30 degree, 30 degree and 20 degree. How much difference is that in the same spherical correction? So everywhere it is not the same focus. So now this spectacle lens is designed shown to be effect for slowing myopia progression are this executive bifocal, or they have tried the PAL, progressive addition lenses, and now designed specifically for myopia control. So to have a peripheral defocus. So this is the important, that they are not focusing same on the phobia and same on the peripheral retina. So they are trying to correct this hyperfocus into a myopic focus. So there is no stimulation for axial length growth. So these are coming, but these are all very, very costly. And this will change after 6 months. So 17, 18,000 or 20,000 lens for a children, and replacing every 6 months, I don't think it is really practically feasible. So things have started moving towards this. Let us see if there is something comes, if something comes slightly less cost, we can prescribe more. So these are the latest on myopia prevention, progression prevention, not myopia prevention. So on, to summarize, is the atropine, and next is the optical corrections are now coming to have this theory of peripheral defocus. Thank you.
Nowadays we are seeing many patients, those who are living abroad, they come for an annual checkup. And I've seen most of them are using these lenses. They are not into drugs.
No, I'm telling you,
And
this is
none
coming.
of them are getting
Maybe
this atropine. I'm seeing, you must be seeing a lot of patients, especially during this time of the year when they come to India, none of them are using atropine.
But many of my patients, But they are using it. They are using it because I know there are patients in Florida and all. They come back to India and they showed me that maybe the off-label they are buying from here, they are taking it, but they are using it. It's not that in America they are not off-label use to hote hi thake. But so this is a nutshell about.
Dr. Saurabh Sannal has suggested doing retinoscopy in 2-3 year babies.
As a routine.
As a routine to assess whether he or she will develop myopia in late age or earlier age or later age or not.
Just note it down.
He has retinoscope, strict retinoscope with him. I have my strict retinoscope in my chamber. Here is prolific phacosurgeon, youngest Dr. Nisha Samadar. Do you keep any retinoscope with you in your personal chamber? You are not in corporate hospital that the optometrist are at a distance place. I am seeing only in slit lamp. But you do your personal chamber like him, like me. Do you keep any retinoscope with you? And you can do that with the baby. That's a nice message.
Why you ask to have a retinoscope with you? Because in my hospital, all kids are having retinoscope done, figure done.
No, keeping a 2-year baby and keeping her on the auto refractometer.
Our optometrists do check.
Devashish da, Devdas da.
हाँ, जार optometrist नहीं ताकि तो retinoscope रखती हो.
Devdas da, my always whenever I speak on this pediatric forum or other forums, I always tell all the listeners that if you see a child, do a distant direct ophthalmoscopy and do a retinoscopy.
Good news for me. I do hypomaxial.
Distant direct ophthalmoscopy also will detect many things in a child.
I have a
many things.
I have also.
Cataract, your amblyopic eye. Difference in glow, Bruckner test. That is called Bruckner test. And if you do it yourself, you do justice to the patient, because most of the optometrists, they will not be able to understand the difference between glow. They can do write down some marks, +1, +2, but this thing, and this is very, very important as far as practicing, seeing many kids in my clinic. সে তো হয় না বলো
Sort of the one question comes to my mind, why only atropine? Where the homatropine, why it's not been tried? It has got the same effect, it causes the same dilatation and the UV factor, whatever. So why only atropine is started? Why homatropine is not been?
Atropine is a more strong antimuscarinic effect. Anti-inflammatory, anti-muscarinic. It acts more strongly on MR receptors.
No, but we are getting very, very low concentration of atropine.
Well, it's okay, but that much of concentration is more effective than homatropine.
না আমার একটা কোশ্চেন আছে, এই যে অ্যাটম স্টাডিজ গুলো হলো, হ্যালো, আমি যেটা জিজ্ঞেস করছি, এই যে অ্যাটম ট্রায়ালগুলো হলো, তাতে কি আমরা কিপিং দেয়ার বাচ্চাগুলোর যে ব্যাড হ্যাবিটস to doing the mobile hours and after hours, keeping that or life some...
No, these are with the normal lifestyle they have studied.
But they are addicted to mobile.
Those are the contributing factors for increasing myopia. Now you have to study that child using 6 hours of screen time and 1 hour of screen time using 1% of atropine.
When you are getting good result may be due to these confounders that the parents are saying, no, don't use the mobile that much, use the...
I emphasize that drug and screen time will not go together.
That means when you are using drug, you must stop using screen time. So that might be the reason
actually, of Devdas,
maybe. That may be.
Maybe.
Actually, Devdas,
calling it is a confounder that is within the system, but you are not analyzing it.
না এগুলো আমি অত ডিটেইল স্টাডি তো বললাম না। না সেটা তুমি you wait for that. There are many more studies coming on progression of myopia. after post-COVID. There are a lot of people are studying that. So this will come. Definitely these studies will come. It is not that...
সৌরভ পারমিশন দিলে এটা ইনিশিয়াল এক্সপিরিয়েন্স বলতে পারি।
হ্যাঁ, নিশ্চয় নিশ্চয়।
মোস্ট নন সাইন্টিফিক, মোস্ট নন ডকুমেন্টেড একটা এক্সপিরিয়েন্স। সো উই স্টাডিড সামথিং ইন ওয়ান অফ দ্য ইউনিট ফর রুটিন স্ক্রিনিং। সাডেনলি দীপ্তেশ আছে তো এখানে, দীপ্তেশ, হ্যাঁ, সাডেনলি হোয়াট উই হ্যাভ ফাউন্ড, এই স্টাডির জন্য লটস অফ যেটা আমরা ক্লিনিক্যালি ডিটেক্ট করতে পারতাম না, ক্যারাটোকোনাস, ক্যারাটোগ্লোবাস, এইগুলো একটা হিউজ নাম্বার অফ কেস হচ্ছে বেড়ে গেল। এক, দুই হচ্ছে আরেকটাও জিনিস হচ্ছে, পয়েন্ট বলে রাখছি, খুব ইনিশিয়াল খুব স্টার্ট হয়েছে যে গ্লাস নিয়ে, কাজলদা বললো না ইট ইজ এক্সপেন্সিভ। ইটস নট, ইট ইজ বেসিক্যালি কেম ডাউন টু, না দাদা আরও কমেছে, না আমার জন্য নয়, এটা বেসিক্যালি দি পলিসিগুলো। ইনিশিয়ালি 8,000 বলছিল, এখন বিভিন্ন কোম্পানি দাম করলে 3-4 হাজার টাকার মধ্যে পাওয়া যাচ্ছে। এটা বাচ্চার চশমা করতে গেলে কিন্তু 1-2 হাজারের মধ্যে করতে হয়। থার্ড যেটা হচ্ছে বেসিক যেটা বোথ অ্যাট্রোপিন এবং চশমায় যেটা হচ্ছে কমপ্লেন আসছে মা বাবাদের কাছ থেকে এবং পেডিয়াট্রিক্সদের কাছে, অল দিজ আর ডিমিনিশিং কন্ট্রাস্ট। তাদের পড়তে একটা অসুবিধা হচ্ছে, স্কুলে এটা স্টাডি করতে অসুবিধা হচ্ছে। তার কারণ এখানে ইলিমিনেশন, যদি আমি যাই না তোমাদের বাকিদের কি
ডিটেইল ওটা নিয়ে আর বললাম না,
তার কারণ এটা ডকুমেন্টেশনে যা আছে তার থেকে অনেক বেশি আসছে। লো ডোজ অফ অ্যাট্রোপিন দিলে পর বা ওই সমস্ত চশমা দিলে পর তাদের একটা পড়াশোনা করতে অসুবিধা হচ্ছে। দে নিড মোর লাইটস বিকজ কন্ট্রাস্ট ইজ ডিমিনিশিং।
আরেকটা স্টাডি দেবদাস দা শুরু হয়েছে, ইউ নো pseudophakic childs are prone to get myopia. pseudophakic child, তুমি যখন ইমেট্রোপিক করলে, মানে আমার করা, ধরো আমার 3 বছর বয়সে করা বাচ্চা 9 হয়ে গেছে মায়োপিয়া। সো এইটা হয়, pseudophakic kids are getting more myopic. সেখানেও একটা স্টাডি ওরা স্টার্ট করেছে। সো টু স্টার্ট with this atropines, whether that reduces the progression of myopia in those cases. So there are many doors have opened after this. These two has come with the progressive peripheral defocus and atropine. Myopia was like that, and ultimately 20 years, 18 years go for LASIK. So that was not now. That is 2 years continuous. Then you stop. Then you see the progression.
না এটাও করেছে, না দুটো মেসেজ বোধহয় খুব পরিষ্কার। at which age that has to be started,
yes,
this is number 1, and up to maximum আমি কতটা দিন এটা কন্টিনিউ করতে পারি। I think
আমরা we start around 5 to 6 years of age if they are significantly myopic, but I don't start. How I start, I say I don't start on the initial days. If I get a myopic child, I ask him or her to come.
Be helpful. This is only working in case of axial myopia.
Yes.
You have to differentiate between other myopia and axial.
Yeah, of course, that's why I told you that if you have an optical biometry, get a biometry done on the first day without touching the eyes. You will have your astigmatism, your diameter of the cornea, your AC depth, everything will be noted in one go. You do it. You do it, and then start around 5 to 6 years of age. 6 months follow up. 6 months follow up for this child on atropine for continuously for 2 years, and then you stop it and see with the progression. If they progress, restart it. And it usually after 14-15 years they don't improve. You can stop it.
Okay. Okay,
Chalo,
with that,
it's okay. Thank you.
With that, we are closing
Thank
this
you.
program. We had a very
Thank
good
you, thank
discussions, and now I'll hand over the mic to Sudipta for the valedictory session.
Just before, a very big thank you to everyone, each of the delegates, for attending this session, and especially to the pharma company who have sponsored this and made this possible. Sun Pharma, Sunways, Entod, Alembic, Ajunta, and Cipla, and if I'm missing anybody, JB Pharma, yes, of course, JB Pharma. And before I just close down, if you just watch, we said that this was the light, the hope that we are lighting right now. It is still there from 9 o'clock in the morning. So that is the message I think I'll pass on before I ask Shibashish to talk to you, that please keep your hopes enlightened, keep up your hopes that we will get some justice out of the protest that we are doing. Thank you so much again.